in today 4 hours and tomorrow 4 hours. Okay. But I am not going to look at the chat box. Okay. So I suggest don't waste time writing in the chat box. You can ask your doubts to me on this number, those of you who don't have it. Okay. I have written on the chat box. And let's have a smooth, continuous session. With the chat box, there's a lot of interruption and it breaks the flow. Okay, so as we did for the INI marathon also, I didn't look at the chat box, and the same will go for here. Any doubts, my numbers on the chat box, you can, most of you have it. Okay, and those who don't can message me separately and ask their doubts. Now, the session is going to be 4-hour session. Okay, that's the plan for us today. We will be covering the high yield obstetric things, and then tomorrow we'll be covering the high yield gynae topics. Okay, so we'll just start in a minute. Let everyone else join, and I hope you're all prepped up for the 20th. And I'm sure all of you will do very, very well. Just scroll back up, you will see the number. 1 second. Yeah, I'm putting the number again. Okay, so everybody has to do me proud and score very, very well in obs and gynae. And overall, of course, yes. Okay, but so let's start. Should we start? Give me a thumbs up and we'll start. Okay. Okay, so today, as I said, we're going to be covering obstetrics. Today's class is on obstetrics, 10th January, and tomorrow will be the gynae class. Okay, so let's start. Now, initially, the most important thing we start off with are the named signs of pregnancy. Okay, so what are these named signs of pregnancy? The named signs of pregnancy are, just a second, just give me a second. The name signs of pregnancy are important because the examiner likes asking these signs. They keep coming in the exam, so should not get this wrong. Okay, so we have two vaginal signs. Jacquemus Chadwick means a bluish hue of the anterior vaginal wall. Okay, so how do you remember this? Jack and Chad saw blue. Okay, and Aussie's pulse increased. What does that mean? Osiander sign is when there are increased pulsations felt through the lateral fornices when a vaginal examination is done. Okay, they're all signs in early pregnancy. Goodell sign is a cervical sign. Okay, so the cervix being soft is a good sign. You can remember it like that. Soft cervix is a good sign. Okay, so the Goodell sign means the cervix becomes soft in pregnancy. This is also around the 6th week. The remaining signs, and out of which most important is the Hagar sign, are all uterine signs. That means on bimanual palpation, when I'm palpating the uterus between my fingers, 2 fingers in the vagina, 1 on the abdomen, these are the signs I feel. But most commonly asked is the Hagar sign. On Hagar sign, what is found? The abdominal and the vaginal fingers appose below the body of the uterus, and this is seen between 6 to 10 weeks. This is the most important. If Pisca sex basically means an asymmetrical enlarged uterus, and Palmer sign is when you're feeling rhythmic uterine contractions, which are very, very subtle. They're not prominent at all. But if you keep your fingers there for a prolonged time, you start feeling contractions. So Jack and Chad saw blue, Aussie's pulse increased, the cervix is soft, which is a good sign. So Goodell sign. Hagar sign is your fingers meeting because the uterus is very soft. Palmer sign is pulsations. Pisca sec is asymmetrical enlargement. So these are all first trimester signs. In the second trimester, what's happening? In the second trimester, the quickening is felt. What is quickening? The first perception of fetal movement. Okay, so in primigravidas, this is felt at 20 weeks, and in multigravidas, this is felt at 18 weeks. Okay, so how can the question come? The question can come, all are signs of diagnosis in the second trimester except. So in the second trimester, quickening will be there, the abdomen will continue to enlarge. Okay, there'll be frequency of micturition, this is mostly in the first and the third trimester. Second trimester, it lessens down. When you examine the patient, what are you finding? You're finding cloasma. What is that? That is pigmentation on the face. Okay, the breast changes become more prominent. These two terms are important. What is external ballottement? That means on abdominal examination, you're able to move the fetus side to side. This is seen after 20 weeks of pregnancy. And internal ballottement means on a vaginal examination, if I just push through the cervix, I can feel the fetus bouncing back on my finger. That is seen earlier, 16 weeks. So internal ballottement is felt earlier, okay, and this is at 16 weeks. External ballotment is at 20 weeks. But what is the most definitive sign? What is 100% telling you that yes, there is a baby inside in the second trimester is auscultation of the fetal heart. So if you're able to auscultate the fetal heart, there is nothing else which will mimic that. There's another live being inside. So it is definitely a pregnancy. That's the most definitive sign of pregnancy is auscultation of fetal heart. And this is earliest at 20 weeks. Okay. So that's if you're asked what's the most definitive sign of pregnancy, the answer is you're able to auscultate the fetal heart. These can come as images. This is external ballotment. Okay, and this is internal ballotment. All right, just to remind you, I'm not looking at the chat box. Their messages piling up. So I'm going to ignore those because it's not even on my screen. So let's just concentrate on the topic and don't waste time chatting. You can message me separately. Okay. Sonography in the second and third trimester, what do we do? So in the first trimester, when we look at the ultrasound, we do a first trimester scan, okay? And there we look most importantly at the crown rump length, okay? And this is going to be the best estimation of gestational age. So crown rump length in the first trimester scan gives us the best estimation of gestational age. Okay, we also do an ultrasound between 11 to 14 weeks of pregnancy. And this is mainly to look at the nuchal translucency, which is for Down syndrome screening. Okay, then in the second trimester, we do a scan between 18 to 20 weeks. Okay, and this is called the TIFA. What is TIFA? It's also called the level 2 scan. TIFA means targeted imaging for fetal anomaly. Targeted imaging for fetal anomaly. And this is in the second trimester between 18 to 20 weeks. It's also called the level 2 scan. What is the level 1 scan? The 11 to 14 week scan is the level 1 scan. Okay. So as I said, CRL, which can be taken till 14 weeks, is the most accurate determination of gestational age. And if you're asked in the second trimester, the biparietal diameter is the most accurate estimation of gestational age. Okay, the abdominal circumference has the greatest variation for gestational age. Next important topic question which comes in the third trimester. So in the third trimester, that means after 28 weeks, we are going to be doing the Leopold maneuvers. Okay, what are these? These are maneuvers which are going to tell us, number one, the lie of the baby. Number two, the presentation. Okay, and number three, whether the presenting part has entered the pelvis. Okay, and number four, which side is the back. Okay, so if it's longitudinal lie, which side is the back? So this is the first grip. The first grip is called the fundal grip. So the hands are on the fundus. So if you get an image-based question like this is a fundal grip. Okay, the second one here, this is Leopold's maneuver number 2, or the second Leopold maneuver. This is the lateral grip. So you can see the hands are laterally. One hand will find out where the back is. That will be a smooth structure. One hand will find out where the limbs are, which will be irregular. Okay. Then comes the third Leopold maneuver. Okay. Also called the first pelvic grip, also called the Pollock grip. Okay. So the first pelvic grip is also called the pelvic grip, and it is done like how is shown. So this is also can come as an image-based question. This tells us what is the presentation. That means what is the part of the fetus occupying the lower pole of the uterus. So it could be the head, that is cephalic, or it could be the breech. So the head either on fundal or on pelvic grip will feel hard and ballotable. That means you're able to move it easily. Okay, so this is how the head feels. If the structure you're palpating is the breech will appear broad and non-ballotable. Okay, so that's important to know how does the head feel, how does the breech feel. Next is this one. This is the fourth Leopold maneuver or the second pelvic grip, or also called simply the pelvic grip. Okay, so you have fundal grip, lateral grip, first pelvic or pollic grip, second pelvic or pelvic grip. And this is the only maneuver where we turn ourselves to face the feet of the patient and we try to approximate our hands. If they are approximating, that means the presenting part, the head is high, it's not yet entered the pelvis. But if our hands can't meet, okay, that means something is in the way, the head is in the way, so it has entered the pelvis. So what is the purpose of the second pelvic grip? Is to tell us whether the head has entered the pelvis or not. So grip 1, grip 2, grip 3, grip 4, you should know this properly. Okay. Now coming to preconceptional care. What is preconceptional care? Before the woman gets pregnant, what are we doing? Okay. So importantly, we are giving folic acid supplementation. Okay. And folic acid supplementation is in two categories. Those who are low risk means any normal patient, okay, without any high risk factors. We start 3 months prior. So 3 months prior to conception, she is to be started on 400 microgram per day folic acid. But if she is high risk, we start at 4 milligram per day. And by high risk, this means there is a history of a previous pregnancy with a neural tube defect, okay, or there is a history of she's known folic acid deficiency, say she was having anemia and she was evaluated, found to be folic acid deficient, or there's a history of epilepsy and she's on anti-epileptic drugs, okay, or she's a known case of overt diabetes. That means she's known type 1 or type 2 diabetes mellitus. That means diabetes which is there before she has gotten pregnant, okay, or if she is obese, okay, or if she's a known sickle cell carrier. That means she has a hemoglobinopathy. These are all your high risk patients who require 4 milligram per day 3 months prior to conception and to continue it in the first 3 months of pregnancy. Now, what is the proven health benefit of giving folic acid? You're reducing the incidence of neural tube defects. So this comes as a question very, very often. The second important thing you should know preconceptionally is if the woman is not vaccinated against rubella. Okay, so how do we know this? We ask her history. Has she taken MMR in childhood? अगर उसको नहीं पता, many patients will not know कि मिला था या नहीं मिला था. So what will we do? We get an IgG rubella tested. Okay, and if the IgG rubella is positive, then what does this mean? That means she's immunized and nothing needs to be done. But if it is negative, okay, we have to give her vaccination. Okay, and what else should we do? We have to tell her not to conceive for 1 month after getting vaccinated. Why is this important? Because rubella vaccine is a live vaccine. It's a live vaccine. So there is a theoretical risk of the baby developing congenital rubella syndrome. Okay. So this is important to know. Rubella vaccination is to be given if the woman is not earlier immunized. That means she's IgG rubella negative, and give the vaccine. Tell her not to conceive for 1 month because of the theoretical risk of congenital rubella syndrome. But suppose she conceives after the vaccine, she can continue the pregnancy. Okay. Remember, if she conceives after taking the vaccine, she can still continue the pregnancy because there's a theoretical risk. The risk is there, but it's very, very small. So ideally advise her not to get pregnant. But if she gets pregnant, it's not an indication of MTP. You can safely allow her to continue the pregnancy. Another very commonly asked area is how to write the obstetric history and the parity index. Now, the formula you should know is the first one, the gravida para living abortion. What is gravida? Gravida is the total number of pregnancies, including the present pregnancy. Okay, what does this mean? If she comes to you, she's the second, if your question comes, she is pregnant for the second time, she's gravida 2. If she's pregnant for the third time, she's gravida 3. If she's pregnant for the second time and is carrying twin pregnancies, she is still gravida 2. So twins, triplets does not increase the gravida or the para, it just increases the number of fetuses. We're not bothered about that. We are defining pregnancy. Pregnancy to ek hi hai, even if it is twins. So it's just the total number of pregnancies, including the present pregnancy, irrespective of the outcomes of pregnancies. Maybe she had an earlier molar pregnancy, or maybe she had an ectopic. It doesn't matter about the outcome, or maybe she had a stillbirth. The total number of pregnancies, including the present one, is gravida. Okay, what is para? Para is the total number of pregnancies that have crossed the period of viability. And we usually take this to be 28 weeks, okay, in our scenario, okay, but in Western countries and developed countries, you'll take this at 24 weeks. Don't worry too much about that. You won't be asked exactly 25 weeks pe kya karoge. No, so they're going to give you very clear-cut scenarios, okay. The total number of pregnancies that have crossed the period of viability, that means even if you deliver the patient, that baby is likely to survive, okay, excluding the present pregnancy. So this excluding the present pregnancy is very important. Abhi wale pregnancy ko nahi count karna. You're not going to count the present pregnancy. You're only going to count all the previous pregnancies that have crossed the period of viability. Okay, that is para. And abortion is anything which is any pregnancy loss before 20 weeks or less than 500 grams fetal weight comes under abortion. So G, gravida को हम G से denote करेंगे, para को P से, and abortion is denoted by A. Okay, and you can also denote living. L means living. How many living children does she have is denoted by L. So remember, important take-home messages from this. Para will not include the present pregnancy. Second important point, para will not include any pregnancy less than 28 weeks. And third important point is that twin pregnancy, chahe gravida ho, para ho, you're going to count the pregnancy as one. So don't make mistakes in calculating gravida para. Okay. Also, don't make mistakes in calculating the estimated date of delivery. Okay. So the EDD is the estimated date of delivery. It's calculated from the LMP. And when I say LMP, and this is asked commonly, it means the first day of the last menstrual period. Not the last day, not the second day, not the third day, the first day of the last menstrual period. So very important, okay? So the patient says, my LMP was on 30th, the patient says my LMP was on 1st December 2023. Okay. Now, how will you calculate her estimated date of delivery? So, what is called as Naegeli's rule? This is called as Naegeli's rule. Now, Naegeli's rule Naegeli was a person who originally described the rule as the first one. That means subtract 3 months and add 7 days. So, we subtract 3 months, we're going to get November, October, September, and then we add 7 days. So, we get 8 September 2024. Okay. Because this was last year. Or we add 9 months and 7 days. So January, February, March, April, May, June, July, August, September. Same thing. So don't get confused by year change, okay? Or different months. You should know how many days in every month. Don't get too confused by that. Simply subtract 3 months and add 7 days, or add 9 months and 7 days. Overthink nahi karna hai. February mein kitne days? 2024, remember, is a leap year. So keep in mind, February will have 29 days. But itna nahi overthink karna, they're not going to confuse you so much. What's important is the EDD falls at how many weeks? It falls at 40 weeks. Okay. And that means 280 days. Now, the question that can come nowadays, we have a lot of IVF pregnancies. In IVF pregnancies, the LMP is not important. What becomes important is the date of ET. What is ET? ET is embryo transfer. Okay. So the patient will remember this date. And to this date, you have to add 38 weeks. Okay, so how do you add 38 weeks? Exam is going to take a long time. So what do? You simply add 9 months and subtract 7 days. Like how we added 9 months plus 7 days is going to give us 40 weeks. 9 months minus 7 days is going to give you 38 weeks. Okay, so embryo transfer ke din ko, you're going to add 9 months and then subtract 7 days. Okay, so that's very important to remember. So take home message from this slide is EDD always ask the first day of the last menstrual period. Nagelli's rule is that EDD falls at 40 weeks, which is 280 days. How do you calculate that? Subtract 3 months and add 7 days, or add 9 months and add 7 days. In an IVF pregnancy, add 9 months and subtract 7 days. Okay, year change and month change should not change your calculation too much. Okay, just a second. As I said, I'm not looking at the chat box because it's going to take a lot of distraction and it's going to take a lot of time. So we'll skip all that. Okay, I'm not looking at the chat box. I know a lot of you are writing on the chat box. 44 messages are there, but I'm not looking. Okay. Now, coming to the next important question is, as per the Ministry of Health and Family Welfare guidelines, okay, the recommendation is, this is your Government of India recommendation, and the FMG paper, the examiners like asking a lot about what is done in our country. So they'll ask you things about the MTP Amendment Act or the MTP Act, favorite question. Okay, they'll also ask you a lot of questions about contraceptives used in India. Okay, and also things which the Government of India will promote. So as per the Ministry of Health and Family Welfare, so if you are asked number of ANC visits, the minimum visits as per the Government of India is 4 visits. As per the WHO also, this question comes often. So look, see the question properly, see what is asked. Don't make silly mistakes in this. If the question is WHO, the answer is 8, and this is called as contacts. They don't call it visits, they call it contact. So 8 contacts. But ideally, and this has come long back, it's come as a question, as per the ACOG, and ideally what we practice is 12 to 15 visits. How is that? Because we call the patient ideally, in my setup, in most setups, what do? We call the patient once every month till 28 weeks. Then we call the patient once every 2 weeks, that is fortnightly, till 36 weeks. And then we call the patient weekly till delivery. Okay, so this adds up to 12 to 15 depending on wo first time kab aayi thi. Okay, so 4 visits by Government of India, 8 visits by WHO, and 12 to 15 visits by the American guidelines, and what is usually done by most practitioners. Now, in pregnancy, diet and supplementation, we've discussed folic acid. Also remember iron supplementation. Again, Government of India program, Anemia Mukt Bharat. You should know this. The Anemia Mukt Bharat program, what does this say? This say for pregnant women. One of the target populations of AMB is pregnant women. And it says for prophylaxis, that means prevention of iron deficiency anemia from the 14th week, that is the 4th month, 14th week onwards, we start iron and folic acid tablets and give it for 180 days during pregnancy and 180 days postpartum. So 6 months antepartum, 6 months postpartum, and each tablet will contain 60 milligram of iron and 500 microgram of folic acid, which is sugar coated and red in color. So remember, this capsule is red in color. It is sugar coated, and what it contains, 60 milligram of iron and 500 microgram of folic acid. This is very, very important. It is very often asked as a question. In addition to all pregnant women in the 2nd trimester and above, we give a single dose of albendazole. This is for deworming. Okay, so this is important in pregnancy. Again, important in pregnancy is tetanus. Now, remember in 2018, again, the Ministry of Health and Family Welfare said no longer will stop giving TT, tetanus toxoid. It replaced tetanus toxoid with TD, tetanus and diphtheria. So that's what we give now. The first dose early in pregnancy. So as soon as she reports to you the first dose, the second dose 4 weeks after the first dose, at least a month gap should be there. And in women who have had a delivery within 3 years of coming again in the second pregnancy, and where she has been fully immunized in that pregnancy, you just give her the booster dose. Okay. Tdap is recommended by the American guidelines. Okay, that means tetanus, diphtheria, and acellular pertussis vaccine. Okay, and this is, so what the ACOG says is give the first one पहला वाला TD दो, and second वाला TD को Tdap से replace कर दो. Second one is Tdap. First is TD, second is Tdap. Okay, but more important is what we do in our country. Okay, so 2 doses of TD. Remember, all COVID vaccines are safe in pregnancy and in lactation. Okay. And yellow, so all live vaccines are contraindicated except yellow fever. Rabies, this bullet should have come here. Rabies is not a live vaccine. Yellow fever is the live vaccine, but it is the only exception to the rule that all live vaccines are contraindicated. Yellow fever vaccine is given if travel to endemic area is there. And if that travel to endemic area can't be avoided by the pregnant woman, she can safely take the yellow fever vaccine. Rabies vaccine, remember, is also safe in pregnancy. So if your question comes that she has a history of dog bite, she's 6 weeks or 10 weeks or 30 weeks pregnant, should she take the rabies vaccine? Yes, she should. It is completely safe in pregnancy. Okay. Now, this is a table of teratogenic drugs. I'm sure in pharma also you'd have covered this, but let's quickly go through it. It's very, very important. Okay. Anti-epileptic drugs are teratogenic. Okay. Remember, the highest teratogenicity is with sodium valproate. Highest risk. Okay. Also, phenytoin causes what is called the fetal hydantoin syndrome. Okay, where there are facial features, there's a lot of clefting, cleft lip, cleft palate, and distal hypoplasia. Then very important, all these have come as questions. AC inhibitors and ARBs, these are anti-hypertensives, completely contraindicated in pregnancy because they cause fetal renal hypoperfusion. So what's going to happen? Urine production is reduced in the fetus and there will be oligohydramnios. In fact, very early onset oligohydramnios is seen. Alcohol causes the fetal alcohol syndrome. Lithium causes Epstein's anomaly. Indomethacin causes premature closure of the ductus arteriosus, but if given after 32 weeks of gestation. Before 32 weeks, you can safely give it. After 32 weeks, you should not give it because it can cause premature closure of the ductus. Why do we give indomethacin in pregnancy? For two main reasons. One is we give it in polyhydramnios, and second, we use it as a tocolytic. What do you mean by tocolytic? Tocolytic means something that relaxes the uterus. Methimazole for hyperthyroidism causes cutis aplasia. Warfarin causes warfarin embryopathy. Thalidomide causes phocomelia. Methotrexate causes clover leaf skull, what is called as craniosynostosis. And DES, diethylstilbestrol, okay, not given anymore, but used to be given long back, can cause clear cell adenocarcinomas of the vagina or the cervix in girls and young women. Okay, it can also cause T-shaped uterus. So women come with infertility. T-shaped uteruses cause infertility. And in men who are born to mothers who had DES, they can have hypospadias. They can also have microphallus. Okay, and there's a higher risk of testicular cancers. Okay, so this table is very, very, very important to know. Next, coming to something called as Down syndrome screening. One question is going to come from here, that is a given. It's going to come. Down syndrome screening has become very, very prominent now. It's done for every woman. It is offered to every woman, and hence it is commonly asked. So this is the level 1 scan. Level 2 kya tha? Anomaly scan, 18 to 20 weeks. Level 1 is 11 to 14 weeks. This is the time we are looking for something called the nuchal translucency, the skin at the back of the neck of the fetus. Okay. And the NT more than 3 millimeter, okay, is suggestive of a Down syndrome baby, but also it's increased in other aneuploidies also, like Turner's, maybe it's increased. Also structural anomalies, so cardiac diseases, okay, or other anomalies also it's found to be increased. Okay, we also look for something called the absent nasal bone. It has been found that babies who have Down syndrome, their nasal bone is not well developed. It may be absent also on the ultrasound at 11 to 14 weeks. So we do the scan, that is the level 1 scan, look for the NT and the nasal bone. Okay, but more importantly is the NT, and we look at a dual or a double marker. This is basically a serum analyte or a biochemical test where we look for two parameters, beta HCG and PAP-A. Okay. Beta HCG in mothers who have a baby with Down syndrome is increased. Okay. And PAP-A is decreased. Okay. How do you remember this? B for big or Barhawa. So increased level of beta HCG is a marker of Down syndrome in women. Okay, and this is done between 11 to 14 weeks. So we can do the scan, we can do the biochemical analytes, or we can do both. Okay, and this is what we usually do because it improves the detection rate. So you're doing an NT plus a dual marker is called a combined screening test. You may actually just get a question, what is combined screening for Down syndrome? Answer is NT plus dual marker. Okay. This is an image-based question. They may ask you identify the measurement being taken. So this is the measurement being taken. This is the nuchal translucency. Okay, the skin at the back of the neck, this measurement is called the nuchal translucency. They may also ask when is it done? Between 11 to 14 weeks. So they may give you this image and say what is the approximate gestational age of this fetus. Okay, it is 11 to 14 weeks because this measurement is taken only at this time. It's not taken at any other time. Okay. Now, second trimester, suppose the patient has not come in the first trimester. She comes straight first time to you at 16 weeks. You can't do the double marker. You can't do the NT. What can you do for Down syndrome screening? You can do what is called the triple test, which is no longer done now. It has been replaced by the quadruple test. These are again blood tests. Okay, what are the markers of the triple test? Again, beta HCG plus maternal serum alpha fetoprotein plus unconjugated estriol. Okay, so this is free beta HCG plus alpha fetoprotein plus unconjugated estriol. Okay, and quadruple is the same thing plus inhibin A. Okay, and what happens to these parameters? So wherever you have a B, that will be increased. Okay, so here also B is increased and inhibin also has a B, so this is increased. These two are reduced. Okay, so very easy to remember, wherever there's a B, that is increased. So beta HCG is going to be increased, AFP unconjugated estriol decreased, and inhibin also, because it has a B, it is increased. Very simple to remember. Wherever there's a B, that parameter is going to be high. And remember, it's inhibin A, not inhibin B. Okay. Now, when we do the TIFA kab karte, the level 2 scan. Remember, we had talked about the level 2 scan, 18 to 22 weeks. It's usually done, or 18 to 20 weeks. But remember, for Down syndrome screening, the ultrasound is not a very great test in the second trimester. Best is the NT, but some small subtle features can be seen in the TIFA scan. They're not important to remember. Okay, but remember it is not a good, it has a low detection rate. The highest detection rate on ultrasound is the NT. Okay, then combined test also has a good detection rate. Quadruple marker also has a good detection rate. Okay, but the best detection rate is this test. This test has the best detection rate of 99%. What is this test? It's a NIPT, full form non-invasive prenatal testing or cell-free DNA. Okay. So what is it? Again, it's a blood test. It can be done anytime after 9 weeks of pregnancy. What are we looking for in that blood test? So this is the fetus, this is the placenta, and the placenta undergoes apoptosis. Okay. Now, the cells undergo apoptosis, some of them, the trophoblastic cells. So the apoptotic cells release DNA. Okay. Placental DNA. That it's not fetal DNA, it's placental DNA into the maternal circulation. So when we take a blood sample, we send it for genetic testing, and what is actually extracted from that blood sample is placental DNA. You'll have maternal DNA and you'll have placental DNA, right? And that placental DNA is subjected to either a FISH or a chromosomal microarray or any of the tests to look for genetic problems and aneuploidies. And this gives a 99% detection rate. But very important, remember, it is a screening test. It is not a diagnostic test. So if NIPT is positive for Down syndrome, you still have to subject her to a diagnostic test. And that diagnostic test is either a CVS or an amniocentesis, rarely a chordocentesis. What does all this mean? All this means that if your NT is high, or if the double marker is positive, or if the combined test NT plus double is positive, or if quadruple marker is showing high risk, or if the NIPT is showing high risk, you are going to offer the patient a diagnostic test. Okay, because those are only screening tests. And you want to confirm your diagnosis before you offer her an MTP, or whether she wants to continue the pregnancy or not. You have to have a diagnosis in hand. Okay, now the diagnosis can be by a CVS, chorionic villus sampling. This is the earliest test that we can do between 10 to 13 weeks of gestation. An amnio can be done after 15 weeks. And a cordo क्या होता है? Cordo होता है umbilical vein. Umbilical vein, you take a blood sample. Okay, and this can be done after 18 weeks. All of these are ultrasound guided. So you look on the ultrasound. If you're taking a sample from the placenta, it's called as CVS. If you're taking a sample from amniotic fluid, it's called amniocentesis. If you're taking a direct blood sample or fetal blood from the umbilical vein, it is called as chordocentesis. Okay. So this is prenatal diagnostic tests. Now we move to the next topic, that is bleeding in early pregnancy. Okay, and three very important causes which we are going to discuss in brief because questions come from all three. So expect one question from here. One question is going to come from early pregnancy bleeding. So abortions, ectopic या molar में से expect one question. Okay. Now abortion we discussed less than 20 weeks or less than 500 grams fetal weight. If it is a pregnancy loss, it is called an abortion. Okay. And here you have different types of abortion. Okay. So why are these important to know? Because you make it a clinical question where they're going to give you some scenario and ask you what is the type of abortion. So the first type of abortion is a threatened abortion. That means there is a threat to abortion. Abortion hasn't actually happened. There's just a threat to abortion. So the common symptoms, what is the clinical picture? There'll be early pregnancy with mild spotting. Okay, maybe 1 or 2 spots of blood or abdominal pain. So abdominal pain, mild spotting is the clinical picture. The size of the uterus is the same as the period of gestation. So patient primary gravida at 10 weeks of pregnancy comes with little spotting and little pain. Okay. With mild spotting and abdominal pain, on examination, the uterus is 10 week size and the internal os is closed. Okay. So this is the picture. There is some bleeding, but everything else looks fine. So on ultrasound, you'll find a fetus. Okay. The cardiac activity will be present if she is more than 6 weeks pregnancy. That's when the heartbeat cardiac activity appears. But you may find a subchorionic bleed. Okay, a collection. What does this mean? That means behind the placenta, there may be this area of bleed. You might see an area of bleed on the ultrasound. What is called as a subchorionic bleed. What is the treatment? Treatment is conservative. We can admit the patient or tell her to rest at home, and we usually support the pregnancy with progesterones. Okay, because the pregnancy that is known to support pregnancy, the hormone that is known to support pregnancy is progesterone. So we're going to give her progesterones either as a vaginal suppository or an oral progesterone or even intramuscular injections. Okay, so conservative treatment. So if there's a threat to abortion, abortion hasn't actually happened. But if this progresses and the fetus gets detached, the entire placenta detaches, and the fetus starts getting expelled, this is called inevitable. Inevitable का मतलब क्या है? अब इसको रोक नहीं सकते हैं. It's going to happen. Okay, it has to happen. So here you'll have a picture of increased bleeding, increased pain in early pregnancy. Usually that's the picture. Okay, size of uterus is the same as the POG or slightly less. Okay, same, slightly less or equal to the POG depending on कितना fetus नीचे आ गया है. ठीक है. Internal os will be open or closed. Internal os will be open. Okay, so remember I square. Okay, so inevitable abortion and incomplete abortion, the internal os is open. So for internal os is open in inevitable abortion and incomplete abortion. All the rest is closed. Okay, ultrasound, what will you find? The fetus is lying low in the uterus or somewhere in the cervix. वो नीचे आ गया. It's come down. It's on the way to getting expelled. What will be the treatment? You want to expedite the process. इसको ऐसे छोड़ दोगे, she will bleed for 2-3 days. You want to remove it because you can't close the os. She's going to expel. So you will help her by doing a suction and evacuation. Okay, that means you will evacuate the contents of the uterus, usually with a suction, like a manual vacuum suction or electrical suction apparatus. Now, next, after incomplete, what happens? There could be, after inevitable, there could be an incomplete abortion. So here the bleeding is much more severe. The pain is much more severe. Okay. And there may be a history of passage of a fleshy mass or tissue. That is the typical picture. Patient will say, I have passed something. Okay, she may even recognize the fetus if it is of a larger gestational age. She'll say, I passed the fetus, I've passed some tissue. Okay, along with the blood. Size of the uterus is definitely less than the POG because most of it has been expelled, but some retained products of conception are seen on the ultrasound. The main fetus has gone. Some placental tissue and bits of tissue are left behind. The internal os is open because jab tak sara nahi niklega, it's not going to close. Okay. Treatment is the same thing. You're going to help the process by doing a suction and evacuation. Okay, so this is an incomplete abortion. Then comes complete abortion. So here there will be a history of pain. There'll be a history of bleeding. She won't currently be bleeding or having pain. She will say 2-3 days back, patient had pain, patient had bleeding, patient had passage of a fleshy mass, but now there is no bleeding. Okay, size of the uterus is less than the POG because she has completely expelled. Internal os is going to be closed. Okay, so because everything has expelled, it closes back. Ultrasound will find an empty uterus, nothing will be there in the uterus, and treatment, nothing needs to be done. Okay, except evaluate her for why she underwent the abortion. For this process, nothing needs to be done because she has expelled everything, nothing is there inside. So threatened abortion, inevitable, incomplete, and then complete abortion. These are the main types of abortion. And then you also have a missed abortion. Okay, now missed abortion and an embryonic pregnancy or blighted ovum. We'll try to understand these other two types of abortions. So what is a missed abortion? Missed abortion means either two things happen. Either the heartbeat disappears. That means there is an intrauterine death, but of early pregnancy. Okay, जब हम IUD बोलते हैं, we usually refer to in the after 28 weeks. So if the fetal demise is happening before 20 weeks, it is called as a missed abortion. That means she had come for a scan at 8 weeks, everything was fine. At 12 weeks, she comes back to you. The classical clinical picture in the exam which comes is that the patient has now whatever vomiting of pregnancy she had, now she feels much better. She's not vomiting anymore, she feels better, but she gives a history of little bit spotting. Okay, so clinical picture is she may or may not have symptoms. Spotting may be there, may not be there. But many times the normal feeling of pregnancy, the breast tenderness, okay, the feeling of nausea, vomiting, all that settles down. And when you do a scan, you find there is no heartbeat now. 8 weeks पे था, अब नहीं है. The other kind of picture is the heartbeat never appeared. So cardiac activity never appeared. And how do we diagnose this? So on ultrasound, we see two measurements. The first thing to appear is the gestational sac. Okay. On ultrasound, this appears at 5 weeks on a transvaginal scan. Okay. Then what appears is the yolk sac. The yolk sac appears at 5.5 weeks on a TVS. And then what appears is the fetal pole, okay, with the heartbeat. So you can see a flicker, a heartbeat. So the fetal pole with the cardiac activity appears by 6 weeks. Okay. Now, when we're doing a scan, we take two measurements. One is we measure the mean sac diameter. So we measure the MSD is the mean sac diameter. And the second thing we measure is the CRL, the crown rump length, which I've already told you. So we measure the crown rump length. Now remember, when the MSD is 25 millimeter, 2.5 centimeters, we should be seeing a fetal pole. So suppose MSD is 25 and I'm not seeing a fetal pole. What is that called? That is called an embryonic pregnancy. That means gestational sac, which is empty. An empty gestational sac is called an embryonic pregnancy or a blighted ovum. Sac hai, but fetus has not formed inside. Okay. And this is called a blighted ovum. That means the fetus never formed. And missed abortion kya hai? Ki fetus ban gaya. So MSD 25 hua, you can see the fetal pole. But when the CRL is 7 millimeter, you should see the heartbeat. So suppose you have a patient, she has no symptoms. You do a scan, you find the CRL is 10 millimeter and you can't see the heartbeat. That means it's a missed abortion. Because at a CRL of 7 millimeter, you should definitely see a heartbeat. So how have we diagnosed missed abortion? Either the heartbeat has disappeared on ultrasound or it never appeared. How do we diagnose this never appeared? That even at a CRL of 7 millimeter, there is no cardiac activity. It is called a missed abortion. Okay. So coming back to clinical picture, she may be completely asymptomatic or there will be disappearance of normal signs of pregnancy. There may be slight spotting. Size of the uterus is less than the period of gestation because the baby is not growing anymore. Internal os is closed. Ultrasound, I told you, the cardiac activity is basically absent. Okay. And treatment, you can either do a medical MTP, give her mifepristone plus misoprostol, what we usually do. Okay, or we can do a suction and evacuation. Okay. Blighted ovum is very similar to missed. The only difference is it's an empty gestational sac. The fetus also, the embryo also is not seen. Which should be seen by 6 weeks is not seen. Which should be seen when the MSD is 25 millimeter. You should see the embryo or the fetal pole. This is not seen. Okay, so same clinical picture. Size of uterus less than the POG, internal os closed. Here you will see an empty gestational sac. Treatment again is the same. You can either give her Mifi plus meso or you can do a dilatation and evacuation. Okay. So what should you remember in this? In this, you should remember the different types of clinical scenarios and how you will diagnose which abortion is which. Okay. Also remember the most common cause of a spontaneous abortion is what? Is a fetal chromosomal anomaly. Okay. More than 50% of spontaneous abortions are because of a fetal chromosomal abnormality. Okay. Next important is recurrent pregnancy loss. So this is just a single abortion. Now suppose she's having recurrent losses. So the classical definition used to be more than or equal to 3 abortions. You'll call it as RPL. But newer guidelines now say that even 2 or more losses, because the patient has to you don't want the patient to be subjected to many losses before you start evaluation. Okay, it's a very traumatic thing to lose a baby. So you start evaluating her after 2 losses itself. Okay, so this is RPL. Primary RPL means she has never had a live baby. Secondary RPL is she's had a live baby and then she's had recurrent pregnancy losses. Okay. So if suppose your clinical scenario comes, okay, and of RPL, patient has had multiple pregnancy losses, 3 pregnancy losses in the first trimester. Some other clues might be given. But if you're given first trimester RPL, start thinking of causes like APLA, okay, or endocrine causes like diabetes, thyroid disorders, luteal phase defects, okay. But if you're given second trimester RPL, of course, other clues will also be given. I'm not saying ignore the other clues. Okay, second trimester RPL, usually think of anatomical problems, okay, like Mullerian anomalies, especially you're worried about cervical insufficiency or incompetence. This is what you should be mainly thinking of in a second trimester recurrent pregnancy loss. And that's what we're going to discuss a little bit. So typical presentation. So patient comes to your OPD and she gives a history of 2 losses at 18 weeks, one at 18 weeks, one at 16 weeks. Okay. And the typical presentation is a painless, okay, recurrent second trimester loss. This is a typical presentation of cervical insufficiency. Why is it painless? It's not actually painless. It just happens so quickly that it is apparently painless. So patient will say that she just was going about her work and she had some cramping pain. And before she even had time to reach the hospital, she expelled the fetus. That is the typical presentation. So painless recurrent second trimester loss, they could be congenital, maybe she has a Mullerian anomaly, very commonly associated with a bicornuate uterus, okay, or it could be acquired. So here your clues are important. The clinical clue might give you that she has a history of a cervical tear, or she's undergone a conization, okay, or she's undergone a cervical biopsy. So here your clues are important. So that's why I was saying they may give you a clue. A patient with a history of conization earlier comes with a history of 2 second trimester losses. What is your diagnosis? So always think of cervical insufficiency in such a case. Okay. So if there is cervical insufficiency, what will you do? You will put in a cervical cerclage. This is a surgical procedure where we're basically, this is the cervix. You're basically putting or encircling the cervix with a suture. You're tightening the cervix so that it holds the pregnancy till term. Okay, so it is done. It can be done either depending on the type of cerclage. You can do it in pregnancy or during pregnancy or in between pregnancies. We will come to that. Okay, in whom is it done? So if you have the classical history, and if you go by history, it should be more than or equal to 3 recurrent second trimester losses. This is one indication of putting in a cerclage. Or if she's had one loss, one or more loss, okay, with a short cervix on ultrasound. What does this mean? So whenever we do your level 1 scan, 11 to 14 week scan पे हम level 1 करते हैं ना, उसी time हम एक और चीज देखते हैं. We see the cervical length. Okay, and a normal cervix should be long, right? In fact, 4-5 centimeters is a good length. But anything which is less than 2.5 centimeters before 24 weeks is a short cervix. ठीक है, तो क्वेश्चन कैसे आएगा? प्राइमी ग्रेविडा with a cervical length of 2 centimeter at 14 weeks. What will you do? So if there's no history of loss, there's no indication of cerclage even with a short cervix. What will you do for such a patient? You also won't leave her alone. You will put her on progesterone. Okay, progesterone will help her continue the pregnancy. So progesterone is the treatment of short cervix without a pregnancy loss. But if there is a pregnancy loss, one or more with a short cervix, then definitely you have to put in a cervical cerclage. तो या तो classical history है 3 or more, या एक से ज़्यादा pregnancy loss हो with a short cervix on the scan, and short cervix on scan means less than 2.5 centimeter before 24 weeks. How do we do the cerclages? We have different types. Okay, so we have the transvaginal types, and here the McDonald cerclage is the most common type of cerclage done is the McDonald cerclage. It is done anywhere between 12 to 14 weeks of pregnancy. It is a vaginal procedure where we put a non-absorbable suture in a purse string fashion. So if they ask what is the purse string suture, it is called the McDonald suture. Okay, and then you remove it at term. It is removed after 37 weeks and the patient is allowed to go into labor. How is it removed? You just cut the knot vaginally. Similar to McDonald's is something called as Shirodkars. Now Shirodkar thoda sa higher level pe place hota hai. Okay, it's higher than the McDonald's. So if the McDonald's is here, okay, here is McDonald's. Shirodkars is little higher. Okay, so to put a Shirodkars, you're going to have to separate the bladder and it's at a higher level. So it's closer to the internal loss. But it is done only in a patient who has had a failed McDonald's. तो directly Shirodkars बहुत कम डालते हैं हम. Only if she's had a failed McDonald's, then we put in a Shirodkars. Okay. And there's also something called the worms cerclage. This is similar to a McDonald. Okay. And one last type, which you don't really need to know, but I'm just adding it here for completion, is the lash and lash. Now, lash and lash, remember these things about it, is never done during pregnancy. बाकी तीनों pregnancy में करते. This is never done during pregnancy. It is done before she gets pregnant. And once you've put the lash and lash, it is always delivery by a cesarean section. Okay, but remember, lash and lash is not usually done. It's never done. I've never seen it being done. So it is, but otherwise, if you've done it, or delivery always by a cesarean, and it is done before she gets pregnant. Transabdominal are two types. One is by laparotomy, one is by laparoscopy. The principle is the same. It is put at the level of the os. So it is the most physiological because the suture is being put at the level of the internal os. Okay. It can be done during pregnancy also, but it is preferably done before pregnancy. Before she gets pregnant, that is the ideal time, but pregnancy may bhi kar sakte hain. The laparotomy one was the first described one. This is described by Benson and Durfee, and that is why it is also called the Benson and Durfee procedure or the Benson's procedure. Okay, so this is what you should know about the different types of cerclage. Okay, and also if you've done a TAC, delivery is again always by a cesarean section. And you remove the TAC only after her family is complete. She wants 2, 3, 4, 5 children. जब family complete हो जाएगी तभी TAC निकालते हैं. Otherwise, it is left inside the abdomen. Okay. Now, question comes on what are the contraindications to cerclage. So, any bleeding to make it a mnemonic, any bleeding, any leaking, any infection. Scenario will come, patient has leaking, but otherwise fits very nicely into cerclage ka criteria. Nahi karoge, you're not going to do. Any features of infection by infection, I don't mean conjunctivitis, I mean vaginal infection. Okay, or infection of the membranes, which is called as chorioamnionitis. Chorioamnionitis. That means placenta या membranes infect हो गए. So any bleeding, any leaking, any infection, any uterine activity, that means uterus is contracting and she's more than 4 centimeters. That means she's in active labor. Nahi dal paoge. It's very difficult. Cervix is so big, you won't be able to bring the cervix together. Or it's an anomalous baby. There's no point putting a cerclage for a baby that is anyway not going to survive. Similarly, a dead baby. Okay, so these are the 5 contraindications to putting in a cervical cerclage. Few lines on APLA. What is APLA? Antiphospholipid antibody syndrome. Okay, just give me a second. Okay, sorry for that. Applies antiphospholipid antibody syndrome. Okay, remember these few things. Diagnosis is Sapporo's criteria, where 1 lab criteria and 1 clinical criteria are required to diagnose APLA syndrome. You don't need to know the exact criteria, but remember APLA is very, very often associated with preeclampsia and abruption. Okay, so if you have a patient with recurrent pregnancy loss, and maybe in one of the losses they give there's a history of preeclampsia, one of the losses they give there's a history of abruption, especially early onset, okay, before 34 weeks. This is a big clue in your question telling you that this may be antiphospholipid antibody syndrome. Okay, also remember that what is the treatment. So if you have diagnosed APLA based on Sapporo's criteria, how are you going to treat APLA? You're going to start her on low dose aspirin as soon as she gets pregnant. Okay, and as soon as the baby's heartbeat appears, you're going to start her on low molecular weight heparin. So aspirin as soon as she's pregnant, and once the heartbeat appears, cardiac activity appears, you're going to put her, let me write this properly. Once cardiac activity appears, you're going to start her on low molecular weight heparin, and you're going to continue this till 36 weeks of pregnancy. Okay, so this is the treatment of APLA, and this is what you should know primarily. Okay, so remember, everybody is going to crack this exam. Okay, you are doing this. You can do this. Okay, so you're not, sorry, you're not here, you're here, you're going to do this. Okay, next important, very important in fact, abortion से तो question आना ही आना है, ectopic और molar से तो double आना ही आना है. So ectopic pregnancy, you know, it can be at any of these sites. The most common site is the tube, the fallopian tube is the most common site of an ectopic pregnancy. In the fallopian tube, the most common site is here. This is the ampulla. This is the widest part of the tube and the most common site for an ectopic pregnancy. But it can be in the ovary, it can be in the abdomen, it can be in the previous scar, it can be even be in the myometrium. It can even be in the cervix. Okay, but we're not going to talk about our main discussion is going to be on the tube. Okay, in a tubal pregnancy. So most common site is the tube, and most common site in the tube is the ampulla. Okay, now just a small word on what is a heterotopic pregnancy. Heterotopic pregnancy basically means an intrauterine pregnancy plus an ectopic pregnancy, usually in the tube. Okay, so you have a nice pregnancy growing inside, and in the tube, you have another pregnancy here. It's very, very rare, but now it's more commonly being seen because of increasing incidence of IVF pregnancy. So remember, IVF causes abnormal implantations. Okay, so this is important because it will be a clue in your clinical question. Patient with IVF conceived. Okay, that will tell you that it increases the risk of ectopic. It also increases the risk of heterotopic because sometimes two embryos or three embryos are transferred. So one may go in the uterus and one may go in the tube. Also remember that what are the abnormal implantation? Other types of ectopic, cervical ectopic can also happen. Even because of this abnormal implantation, you can also have a higher instance of placenta previa in IVF pregnancies because the embryo gets implanted in the lower part of the uterus. So it starts growing there, so placenta previa. Okay. So risk factors, IVF is one, history of tubal surgery. Why are risk factors important for your exam? Because they form the buzzwords, the clues for answering your questions. Okay. History of tubal surgery. She has history of tubal ligation and she comes with a pregnant UPT positive with pain, with bleeding. So whenever there's tubal surgery, alarm bells should ring with the classical triad of symptoms, pain, bleeding, amenorrhea. Start thinking of an ectopic pregnancy. Okay. There's a history of pelvic inflammatory disease. There's a history of genital tuberculosis. There's a history of previous surgery. There's a history of adhesions. This is because of a previous surgery, or there's a history of endometriosis. What are all these things doing? They are affecting in some way or the other, they're affecting the tube. A tubal surgery, PID, you know, the most common organ to be involved in PID is the tube. So salpingitis. Genital TB, also the most common organ to be involved is the tube, salpingitis. Adhesions may hamper the movement of the tube, and endometriosis also may hamper the movement of the tube. Okay, so these are risk factors for ectopic pregnancy. This slide is not clear, but it's basically trying to show you the classical triad of ectopic. So pain plus bleeding plus amenorrhea, and usually they would give you that the UPT is positive, and it's usually an early pregnancy which will present with these symptoms. So pain, amenorrhea, bleeding is the classical triad of ectopic pregnancy. Now, when you come to clinical scenarios, okay, remember, if it's, what are we worried about in an ectopic pregnancy? We're worried about the ruptured ectopic. And a ruptured ectopic will have the most severe symptoms and signs. The patient will come in shock. So there will be tachycardia, there will be hypotension, there will be abdominal guarding and rigidity. There will be severe pallor. Okay, apart from your classical triad. Classical triad, it's not necessary all three will be there, but one or two or maybe all three. With these things, always think of a ruptured ectopic. Ruptured ectopic patient, the exam scenario is going to be a patient in shock. And if your exam question says that patient comes, she's a primigravida conceived by IVF, has come at 6 weeks pregnancy with spotting and severe abdominal pain. When you examine her, there is tachycardia, hypotension, guarding rigidity. This will be given. What is the next best step? So you've diagnosed ruptured ectopic by seeing this clinical scenario. You're going to directly take her up for surgery. Okay. You're going to do a laparotomy. And what are you going to do when you open the abdomen? You're going to remove the tube. It's a ruptured ectopic. The tube has to be removed. So you're going to do a salpingectomy. The tube has to be removed. Okay. The problem comes in diagnosing an unruptured ectopic. Okay, that is where you're going to do your ultrasound, the beta HCG, the other things. But remember, ruptured ectopic is a clinical diagnosis. You're not going to waste time doing things when the patient is in shock. You're not going to waste time on a scan or a culdocentesis or anything. Only if the patient is stable and you have time and you are doubtful of rupture, will you resort to other things. But if your question comes as patient is in shock, and this is how you will know, you are not going to waste time. You're directly going to do a surgery. Okay. If the patient is unruptured ectopic, so she's going to come with a classical triad, pain plus bleeding plus amenorrhea. Okay. तो ये तो हमने in abortion में भी देखा, it could be an incomplete abortion, it could be inevitable, it could be threatened abortion. So what's the first thing we're going to do? The first thing we're going to do when the patient comes with triad of symptoms and she is clinically stable, the first thing you're going to do is a transvaginal scan. Okay, you're going to do the imaging first. This is the first investigation or the next best investigation if this is your clinical picture. Triad plus clinically stable, because it may even be an abortion, it may be a molar pregnancy, it could be an ectopic, we don't know. Okay, but she's stable. So if she's an ectopic, what are you going to find? You can find this. What is this? This is the uterus. And inside the uterus, what are you seeing? This is not a gestational sac. Gestational sac होता तो यहाँ दिखता और अच्छे से round दिखता. This is a pseudo sac, okay, which is fluid collection inside, seen in an ectopic pregnancy. Okay, fluid collection inside the uterus. Or you may actually see the sac with the yolk sac outside the uterus. You're actually seeing the ectopic gestation here. The uterus is here. This is separate from the uterus. Or you may see, again, the same thing. The uterus is not seen in this picture, but the ovary is seen. Next to the ovary, you're seeing this. This is called what sign? This is called a bagel sign. Okay. Can you see this? This with this. It looks like a donut, but donut नाम नहीं दिया इसको, bagel दिया. Bagel क्या होता है? Donut is sweet. A bagel is a bread which looks like a donut. Okay, so bagel sign. Another sign is the blob sign. Okay. And this, what is this? This comes as a question so many times. It's come ring of fire sign. So this is, while doing the scan, we switch on the Doppler. Doppler क्या बताएगा कि blood flow कितना है वहाँ पे? How much is the blood flow? If the blood flow is all around surrounding this unruptured ectopic, it is called the ring of fire sign, typically seen in an unruptured ectopic pregnancy. Okay, so patient comes like this, we do a TVS, we see the bagel sign, we know this is unruptured ectopic, and accordingly I will manage her. But sometimes TVS clear nahi hota. If the TVS is not clear, what am I going to do next? And then I'm going to do the beta HCG. So when you have the classic triad with patient stable, with TVS inconclusive. Inconclusive means nothing is seen. What is this called? This is called a pregnancy. Nothing is seen means intrauterine भी आपको pregnancy नहीं दिख रहा, extrauterine भी आपको pregnancy नहीं दिख रहा. This is called a pregnancy of unknown location. Okay, this is called a PUL. So if you have a scenario like this, the exam question will come like this. Then you have to do a beta HCG and repeat it after 48 hours, what is called the doubling time. So do a beta HCG and repeat after 48 hours. If it's an intrauterine normal pregnancy, what's going to happen? The beta HCG is going to double. That means doubling is a misnomer. It's actually going to increase by 60%. So if it's 100 today, परसों कितना होना चाहिए? It should be at least 160, more than 160. Okay, this is called doubling, and this is in a normal intrauterine pregnancy. तो ectopic में क्या होगा? Ectopic में grow करेगा, but it's not going to double. So if it's 100 and then it's 120 after 48 hours, you are worried about ectopic. That's one thing. The second important thing of beta HCG is the discriminatory zone. What does this mean? This means only when the beta HCG reaches a value of 1500 will I be able to see an intrauterine pregnancy on the TVS. Okay, so in a pregnancy of unknown location, I'm not seeing anything. Maybe it's because it's a normal intrauterine pregnancy, but the beta HCG value is still less than 1500. Okay, so that's what is discriminatory zone. And if you're doing a trans-abdominal scan, this value is taken as 6000. Okay, so these two things, the doubling time and the discriminatory zone, help us to further clarify what this could be. Okay, because I do not want her to rupture in the interim. जब तक मैं diagnosis नहीं करती हूँ, I can't leave her alone. Okay, and just pray to God and say, let's just see what's best. No, I have to try to diagnose her by these two things. Okay, so positive UPT plus pain plus bleeding, unstable patient in shock, your answer is going to be salpingectomy. Okay, if she is stable, okay, I am going to do a transvaginal scan. Okay, it might be an intrauterine pregnancy, maybe it's a threatened abortion or an incomplete, inevitable, whatever, we've discussed that. Or You see the bagel sign, you see the ring of fire. So it's an ectopic pregnancy. Or it is a pregnancy of unknown location. And here I will do a beta HCG at 0 hours and repeat at 48 hours. And this will give me a clue of what we are dealing with. Ruptured ectopic ऐसे दिखेगा, blood ही blood दिखेगा. So here, can you imagine this patient bleeding? You're not going to do anything conservative. You're going to directly do a laparotomy एंड सैल्पिंजेक्टमी. ये पिक्चर लैप्रोटोमी का है या लैप्रोस्कोपी का है? दिस पिक्चर इज एक्चुअली अ लैप्रोस्कोपी पिक्चर. ओके, बट फॉर ऑल फ्रॉम एग्जाम पॉइंट ऑफ व्यू लैप्रोस्कोपी नहीं करते हैं फॉर एक्टोपिक रप्चर्ड एक्टोपिक. वी डोंट डू लैप्रोस्कोपी फॉर रप्चर्ड एक्टोपिक. फॉर ऑल प्रैक्टिकल पर्पसेस वी डू लैप्रोटोमी बिकॉज इट इज अपेरेंटली क्विकर एंड salpingectomy. तो एग्जाम में लैप्रोटोमी एंड salpingectomy फॉर ruptured ectopic pregnancy. This is an unruptured pregnancy. This is a laparoscopic image of an unruptured ectopic. You can see this is the fallopian tube and this is the ectopic pregnancy here. This is the uterus. This is the ovary. Okay. Now, if it's an unruptured, if you diagnose an unruptured tubal ectopic, there are 3 ways we can manage this. We can either give her expectant. We can either give her methotrexate, that is medical management, or we can post her for laparoscopy. But how do we decide what to do comes as a question. It's very important to understand कि कब expectant करोगे, कब medical करोगे, कब surgical करोगे. So expectant management is done in patients who have no pain, okay, whose beta HCG values are less than 1000, okay, who have a gestational sac size on the ultrasound, that is in the tube, that bagel sign you're seeing, that should be less than 3.5 centimeter, and there's no cardiac activity. That means उस bagel sign के अंदर embryo नहीं दिखना चाहिए और heartbeat उस embryo में नहीं दिखना चाहिए. Okay, so this is when you will do expectant. Expectant का मतलब है कुछ नहीं करोगे. You will just do weekly beta HCGs and see how it's going. It should fall because most ectopic pregnancies, what is going to happen? Rupture नहीं होते most. Most of them will resolve by themselves. So most ectopics will resolve by themselves. Okay, very few will rupture, but we are still very worried about rupture because you can lose a patient also. So you should know how to manage. Okay, so how do you remember this? What's the mnemonic? There's no pain in giving rupees 1000 and having no pain and no heartache. In giving rupees 1000 and having it returned in 35 days. ठीक है, पेन नहीं है, हार्टबीट नहीं है, 1000 से लेस है बीटा HCG और 3.5 सेंटीमीटर से लेस है the gestational sac size. Then what do? We can just tell the patient this is most likely going to resolve. Let's just follow you up with a weekly beta HCG. Okay. Next is medical management. Now, when will you give methotrexate? And how much methotrexate do we give? We give 50 milligram per meter square. Intramuscular injection is given. Okay, but when do we give this? This is if the patient is having mild symptoms, so mild pain. Okay, beta HCG less than 5000. Okay, then sac size is the same, less than 3.5 centimeter, fetal cardiac activity absent. Okay, and no contraindications to methotrexate. She's not severely anemic or has a chronic kidney or liver disease, and she's willing for follow-up. Willing for follow-up is very important. She should not just disappear, okay, and come back in the emergency with a ruptured ectopic, because we're going to repeat her beta HCG levels on day 4, day 7, and then weekly. It should be decreasing. Okay, if on day 4 you find a higher value, you can repeat the methotrexate. Okay, so this is the medical management of ectopic. She may be having mild symptoms, but beta HCG less than 5000, SAC less than 3.5, no cardiac activity, and no contraindications to methotrexate. You will give her medical management. Surgical management कब करोगे? when she has a lot of pain. Okay, when the beta HCG is more, so any of these or any of these, beta HCG more than 5,000. Okay, sac size more than 3.5 centimeter, cardiac activity present. Okay, in such situations, you will do surgery. What surgery do? We do a laparoscopy. Here, there is no hurry. The patient is not in shock. We can do a laparoscopy. Laparoscopic, either we can conserve the tube. So you can either do a salpingostomy or you can remove the tube, salpingectomy. Okay, but surgical management you will do in these situations. So there's a lot of pain and heartache in giving rupees 5,000 and not returning it in 35 days or returning it after 35 days. That's the mnemonic for learning surgical management in unruptured ectopic. ठीक है, laparoscopic salpingostomy कर सकते हो. That means you're just making a hole in the tube on the anti-mesenteric surface, mesosalpinx के opposite side पे, and evacuating the products, or you're removing the tube. ठीक है, पूरा tube कब निकालोगे? So usually we do a salpingostomy if the patient has infertility and wants to conserve the tube. But there's a very good chance she might have an ectopic again in that same place. So salpingectomy is preferred if the family is complete, if she's had a previous ectopic at the same site, okay? If she's had the ectopic, this ectopic at the site of tubal ligation, or if it's a grossly distorted tube. That means pura tube ही इतना बड़ा एक topic है, pura tube ही enlarged है. There's no point conserving that tube. Okay, so these are the indications for doing a salpingectomy even in an unruptured ectopic. If the patient is young, infertile, wants more children, you can explain to her the risks and do a salpingostomy. Okay, so this is about ectopic pregnancy. तो क्वेश्चंस कैसे आते हैं? क्वेश्चंस आते हैं ऑन द टाइप ऑफ मैनेजमेंट. अपार्ट फ्रॉम वन लाइनर्स, you're going to get clinical questions, or they're going to give you some features and say what is best, expectant, medical, or surgical, and what type of surgical. You should know that if it's ruptured ectopic, salpingectomy. If it's unruptured, you can do either of them. Molar pregnancy, very important. Okay, so WHO has classified gestational trophoblastic diseases into molar pregnancies and trophoblastic tumors. ठीक है, molar में क्या क्या आता है? H mole आता है, and in this you have complete and partial, and also it's given invasive mole under H mole. Now invasive mole is nothing but a locally invasive choriocarcinoma. That means it is limited to the uterus. Okay, but the treatment of chorio and invasive mole treatment is the same. Okay, just in the classification they've put invasive mole under molar pregnancies. But treatment of invasive mole and a choriocarcinoma are the same. That is, we give chemotherapy. Okay. Placental site trophoblastic tumor, epithelioid trophoblastic tumor. These are very rare variants of trophoblastic tumors. Okay. Now here we have a partial mole. So this first one is a partial mole, and here is a complete mole. What is happening? Can you see what is happening? One egg is being fertilized by two sperms. So as a result, what is forming? A triploid embryo has formed, which is 69XXY or 69XYY. But it is triploids. Remember, 69, if you're seeing, it is a partial mole. Complete mole is always diploid. Okay, because a complete mole, what is happening? The sperm, you can see the sperm is fertilizing an empty ova. That means there is no genetic material here. And then it undergoes androgenetic duplication. Okay, so all you're having in this complete mole is only paternal DNA. There is no maternal component at all. Okay, in a complete mole. So remember CD, in the alphabet C and D come together. So complete moles are always diploid, partial moles are always triploid. That's the first thing you should remember. Okay, so partial moles are triploid, complete moles are diploid. Okay, partial mole presents very similar to a missed abortion. Okay, you don't see the classic grape-like vesicles. So complete mole, you'll have the classical grape-like vesicles. You'll see very high beta HCG levels. Uterine height more than the POG. Okay. Theca, big theca lutein ovarian cysts. These are all typical features of complete mole. Partial mole is very similar to your classical triad of pain, bleeding, UPT positive. ठीक है, ये सब नहीं दिखेगा. पर complete mole में you'll see grape-like vesicles, very high beta HCG levels, theca lutein cysts, uterine height is big. Okay, and remember, complete mole has a higher chance of becoming choriocarcinoma. Okay, whereas a partial mole has a 5% chance, choriocarcinoma has a 15% chance of turning into malignancy. Now, in histopathology, what do you see? What are the important things? Remember these two words, villous edema and trophoblastic proliferation. ये दोनों यहाँ, in partial, they are focal. Only in some areas you will see villous edema and trophoblastic proliferation. In complete, they are diffuse. So all over you're going to see only this. Okay. Also remember, fetal parts are seen in a partial mole. They are absent. Fetal parts, fetal RBCs are present in a partial mole. In a complete mole, आपको कोई fetal part, fetal RBC दिखेगा ही नहीं, because that's never formed. Okay, also remember, atypia is seen with complete mole. That's why the risk of malignancy is also higher. And there is something called the P57 KIP2 immunostaining. Remember, this is present in a partial mole and absent in complete. क्यों? क्योंकि P57 KIP2 is seen only when there is maternal tissue present. ठीक है, maternal tissue कहाँ पे होगा? In partial mole. It is absent in complete mole. Remember, complete mole, there is no maternal component. So this staining will be negative. Typical image-based questions you will definitely get. If you pick up your last FMGE papers, at least 4 to 5 times this has been asked in the last 5 years. What is this? This is snowstorm pattern. ओके, सीन ऑन द अल्ट्रासाउंड. ये क्या है? ये जो ब्लैक ब्लैक चीजें दिख रहे हैं, these are the grape like vesicles. You can even get a picture like this. These are the fluid filled vesicles. ठीक है, so grape like vesicles, snowstorm appearance, typical images from molar pregnancy. What do you do if you get a question on management of molar partial ho, complete mo? What you're going to do? You're going to do a suction and evacuation. That means you're going to, this is the uterus. Okay, this is the grape-like vesicles filled inside. What you're going to do, you're going to dilate the cervix with a Hagar's dilator. So it's actually a dilatation and evacuation using a suction apparatus. So dilate करोगे, फिर क्या करोगे? फिर आप अपना, you're going to put a suction cannula inside, a Carman's cannula, attach it to the electrical suction apparatus or the MVA syringe. Okay, and you're going to evacuate all the products. So a suction and evacuation, you're going to suck out everything, is the management of choice. Okay, but इसको खत्म नहीं होगा यहाँ पे. You're going to do something additionally. You're going to do a beta HCG surveillance. Why do you do this? Because you want the beta HCG to come down to 0. Okay, if it's persisting in the blood, that means this has become a choriocarcinoma. Okay, so beta HCG surveillance is very important. So post-evacuation surveillance with beta HCG is done. Levels, so how do we do this? We do this weekly. So after this evacuation is done, we do weekly beta HCG till this value touches 0. And then you check the beta HCG monthly for 6 months. Okay, so this value will touch 0 usually by 7 weeks in a partial mole and 9 weeks in a complete mole. Okay, and as I said, remember 5 and 15, the risk of GTN basically means choriocarcinoma is higher with a complete mole and lesser with a partial mole. Okay, so that is why we are doing this, because what's going to happen is when we are following this patient up, before we did the evacuation, the value was 1 lakh, right? And after evacuation, it starts dropping down. So by 9 weeks, it will touch zero. ठीक है, ये हमारा graph है. We always plot this graph when a patient we're following up with of molar pregnancy. Suppose ये fall होते होते ऐसे चला गया. This is called as plateauing. या फिर it starts rising again while checking her. Okay. Or even after 6 months, you're still finding beta HCG in the blood. वो zero कभी हुआ ही नहीं. It's never touched zero even after 6 months. Okay. Or this patient comes with an episode bout of bleeding. You do a scan, you find something in the uterus. You do a you take a biopsy from the uterus and you find histopathological diagnosis of choriocarcinoma. So that's how you diagnose GTN. GTN का मतलब choriocarcinoma. कैसे diagnose करोगे? It's either plateauing or it's rising. Forget the other things. Okay, just remember plateauing or rising, or even after 6 months of evacuation, beta HCG is still in the blood. Or you do a biopsy from the uterus because of persistent bleeding and you get a histopathological diagnosis. Any of these four becomes your diagnosis for choriocarcinoma. Okay. Now in GTN, वो हमने discuss किया molar pregnancy. Now we're on GTN. GTN means choriocarcinoma. If you've diagnosed choriocarcinoma, remember the first thing you need to do is to risk score her. So risk scoring is important, and once you've scored her risk, you will give chemotherapy. So the risk scoring is going to tell you the type of chemotherapy. If she's low risk, you're going to give her methotrexate. But this is not like the ectopic methotrexate. Here you're going to give multi-dose. That means you're going to give on day 1, 3, 5, 7, 1 milligram per kg of methotrexate, and alternate this with day 2, 4, 6, 8 of folinic acid. Okay, and you give this regime every 3 weeks. Not very important, but just remember you don't give a single dose, you give multi-dose methotrexate. And if by the risk scoring she is high risk, you give multi-drug chemotherapy. You give EMACO. Okay, what is EMACO? Etoposide, methotrexate, actinomycin, D, cyclophosphamide, and sorry, and oncovin. Oncovin. Okay, so this is multi-agent chemotherapy in high risk. Okay, now this is the risk scoring table. You don't have to remember this, but just remember so you have these parameters here. Okay, and you have the scoring 0, 1, 2, 3. Just remember 0, 1, 2, 4. Just remember the zero score. So young age is 0. A previous mole, remember term pregnancy के बाद भी choriocarcinoma हो सकता है, and that's a very bad thing to have. But if it's after a mole, it's a good thing. If it happens very early after molar evacuation, it's actually a good thing. If the beta HCG levels are not very high, it's a good thing. If the tumor size is less, it's obviously a good thing. Very important, remember lung metastasis, what are called as cannonball metastasis, are actually a good thing. So you see in the exam, in the question, it will come lung metastasis or cannonball metastasis. Don't think that is a high risk. Lung metastasis are actually a score 0. They respond very well to chemotherapy. Okay, so it's good to have lung metastasis in choriocarcinoma. So if your score is less than 6, if it's a young patient, recently had a molar evacuation, low beta HCG levels, lung metastasis, you can safely give her methotrexate. But if, and the risk of response to chemotherapy, it's a highly curable tumor, is 100%. Okay, if she's high risk of treatment is a little lower, but still good. And here you give EMACO. Okay, that is multi-agent chemotherapy. Okay, so don't last minute try and remember this table, not important. Okay, so let's just take a 2-minute quick break and then we get back. Okay, just 2 minutes. I'm here only, I'm not going anywhere. Okay. Uh, so let's get back. Again, a very important topic, and a lot of questions come from here as image-based questions. Okay, especially the ones related to the placenta. So, what is a normal placenta? What are the features of a normal placenta? It is discoid. This means it is round in shape. Okay, it weighs about 500 grams. The diameter is 15 to 20 centimeters thick. Okay, sorry. Diameter length is 15 to 20 centimeters. The thickness is 2 point, and these have all come as questions. That's why I'm telling you. Okay, thickness is 2.5 centimeters, and it has around 500 ml of blood in it. Okay, so this is basically what is a normal placenta. It also has two surfaces. This is the fetal surface, the shiny surface where the umbilical cord side, for obvious reasons, this is going to be the fetal side because the umbilical cord is here. Okay, and you can see the branching out vessels like this. And here is the maternal side. So the maternal side is the dirty looking side where you have multiple cotyledons. Okay, and you have 15 to 20 cotyledons. This is one, this is one, this is one, this is one. So 15 to 20 cotyledons in a normal placenta. So you should know the features of a normal placenta. I'll repeat: 500 grams, round in shape, 15 to 20 centimeter diameter, 2.5 centimeter thickness, a shiny fetal surface, a rough maternal surface which has 15 to 20 cotyledons. What is this? This is a bilobed placenta. It usually doesn't have much significance clinically, okay? But yes, there could be a small risk of a retained placenta here, okay? But this, you should be able to identify this bilobed placenta. If the second lobe is smaller, it is called a succenturate placenta or placenta succenturata. So you have a smaller second lobe. Again, here you have the risk of a retained placenta. And one more smaller risk is there with both a bilobed and a succensurate is this central area. Can you see this area? If this is overlying the internal os, okay, this area is overlying the internal os, there are vessels here. Can you see? It's more clear here. You can see the vessels here. What's going to happen is that vasa previa. That means if you rupture the membranes here, a fetal blood vessel can get ruptured, and this will lead to fetal blood loss and severe fetal anemia. Okay. And fetal death also. So this is called as vasa previa. So vasa previa is seen in placenta succenturata and also in something called as this. What is this? This is velamentous insertion. So can you see what's happening here? The cord is inserting into the membranes. Normally cord should insert here, right? The cord should come here, but it's inserting much before into the fetal membranes. This is called a velamentous insertion. And again, if this area is overlying the internal os, when you do an artificial rupture of membranes, you're going to lead to vasa previa. So easy to remember, V for V, velamentous insertion, vasa previa. But also vasa previa is seen with placenta succenturata, also a retained placenta. What is this? This is a circumvallate placenta. What does this mean? This is the membrane, amniotic membrane. So amniotic membrane should cover this whole area. Okay, but it is deficient. It is not able to cover the entire fetal surface. It is deficient and it rolls upon itself to give this thick white rim appearance. So remember this picture, typically circumvallate placenta. And here you have typical associations. It's associated with a higher risk of intrauterine death, of preterm labor, of preeclampsia, of fetal growth restriction, and of abruption. Okay, all this is higher if the placenta is circumvallate placenta. Okay, so remember this picture of circumvallate placenta. What is this abnormality? What is happening here? Again, the cord should insert here. Here it's inserting in the placenta, not the membranes, but it is at the edge or a marginal insertion. This is called a battle door. This is the correct spelling. Battle door placenta. That means it is an eccentric or marginal cord insertion. It has no clinical significance. All right. This we've discussed filamentous insertion. Okay, sometimes what you see is so the umbilical cord contains three vessels. Okay, so normally it is a three vessel cord is normal. And what are the three vessels? You see one umbilical vein and two umbilical arteries. This is normal. Remember, one vein and two arteries. So look at this. This is an ultrasound picture. Can you see this structure? This is a transverse section through the umbilical cord. Okay, so this is the umbilical vein. Okay, this is the umbilical vein, and these two smaller chotu arteries are the two umbilical arteries. This is how the cord looks like on transverse section on the ultrasound. This is called the Mickey Mouse sign because those two arteries look like two ears of Mickey Mouse. So this is the Mickey Mouse sign. Now look here, can you see here there are only two vessels, one umbilical artery, one umbilical vein. Vein is usually the bigger one, okay? So here you have a single umbilical artery or a two vessel cord. Now this is associated with a higher incidence of chromosomal aneuploidies and also of structural fetal anomalies like cardiac anomalies, like renal anomalies, like skeletal anomalies. So cardiovascular, renal, and skeletal abnormalities are more commonly associated. Also, aneuploidies are more commonly associated with a single umbilical artery. Now coming to amniotic fluid abnormalities. Okay, now this question has come in the past. There's been a lot of confusion in this question, but remember this was asked. The peak amniotic fluid, and this table is from Williams. Okay, so this is the standard book. The peak of amniotic fluid happens at 36 weeks. Okay, but that option wasn't there, I think, in the question that was asked. So the next closest answer is 34 weeks, not 32 weeks. Okay, so peak amniotic fluid, the best answer is 36. The next best answer is 34 weeks. Remember, after 36 weeks, it starts reducing in quantity. Okay, and more so after 40 weeks. That's why we don't let the patient go beyond her estimated date of delivery because of the risk of oligohydramnios. Amniotic fluid decreases, and post-term, that means after 42 weeks, it becomes significantly less. Different colors of amniotic fluid. The colors haven't come here. I'm so sorry. On the PPT, they were there, but let's color them now. This is a straw colored clear amniotic fluid. This is normal. Okay. What is this color? If I'm to show you this green color is meconium staining. Now, meconium is a sign of two things. It's either a sign of fetal distress, okay, or it's a sign of fetal maturity. So a baby who is post-term after 42 weeks, baby may not be distressed, but you find the color of liquor is green. When do we see this color of liquor? When we do an artificial rupture of membranes when the patient is in labor. Why do we do an ARM? ARM is done to augment labor. That means to increase the uterine contractions. Okay, and the biggest advantage of doing is an ARM is you see the color of the liquor also. So if you see green, you start getting worried that this could be fetal distress. What is this deep yellow color? Deep yellow color. So deep yellow is a sign of fetal anemia. Okay, because amniotic fluid is nothing but the fetal urine, right? So you're basically taking out the fetal urine and seeing the, so when you do an ARM, the amniotic fluid which comes out is nothing but a reflection of the fetal urine. In patients who are in fetuses who are Rh isoimmunized, fetal anemia is happening, and because of that there is unconjugated bilirubin, and that results in this deep yellow color of urine. What is this? This is tobacco colored amniotic fluid. This is seen in fetal demise or intrauterine death. Okay, and the last color which I wanted to show you is this one, red in color. Red color is seen in abruption. So if your question comes that a patient is in labor Okay, and on doing an ARM, you find that the amniotic fluid is red in color and there is also sudden fetal distress. So what has happened when you do an ARM? Suddenly there is decompression of the contents of the uterus and the placenta gets separated. So you'll have fetal distress, you'll have blood-stained amniotic fluid, that is abruption. So that's how your clinical question can come. So these will help you in answering your clinical questions. Now, another important aspect of amniotic fluid is the measurement. So there are two ways we can measure the amniotic fluid on ultrasound. This is ultrasound measurement is by doing an amniotic fluid index, okay? Or we simply take the largest vertical pocket or the deepest vertical pocket. Now you should know the normal values. AFI normal is between 5 to 25 centimeters. Less than 5 is oligohydramnios. More than 25 is polyhydramnios. DVP means the deepest vertical pocket. Okay. And here we take the normal between 2 to 8 centimeters. Okay. Less than 2 is oligo and more than 8 is poly. Difference क्या है? AFI में हम 4 quadrant ले रहे हैं. We're taking 4 quadrants and adding it up. In this one, we're taking a single quadrant and seeing the amount of amniotic fluid. So it's important to remember both, but more commonly we do an AFI. Normal AFI is between 5 to 25 centimeter. If the AFI is more than 25 centimeter, it is polyhydramnios. If the AFI is less than 5 centimeter, it is oligohydramnios. Okay, so this is diagnosis of poly and oligo. If we take the deepest vertical pocket more than 8 centimeters and here the deepest vertical pocket less than 2 centimeters. Okay. Now, what are the causes of polyhydramnios? This very often comes as a question. Okay. The most common cause is idiopathic. That means there is no known cause. We don't know, but likely is more. Okay. But other than idiopathic, you should know important fetal anomalies that can cause polyhydramnios. Okay. In this, we have open neural tube defects like anencephaly. Why? Because the CSF is just continuously leaking into the amniotic cavity. It's an open neural tube defect. There's continuous leakage of the CSF outside. Second is if there's any obstruction to swallowing. Okay, so amniotic fluid is formed by fetal urination and it is circulated by fetal swallowing. The fetus is going to swallow the amniotic fluid. So there's an obstruction like a large neck swelling, like a cystic hygroma, or if there is tracheoesophageal fistula, or if there's duodenal atresia or ileal atresia. So any obstruction in the GI tract is going to cause polyhydramnios. Okay. What else should you remember? Whenever there's increased fetal urination, and this is seen in diabetes mellitus. So if the mother has hyperglycemia, the baby will also have hyperglycemia. So polyuria in the baby. And very important other cause, twin-to-twin transfusion syndrome, where one baby will have poly and the other will have oligo. So in twin pregnancy, monochorionic diamniotic twins, sometimes you see TTTS, which is called the oligo-poly sequence. So poly could be a cause here also. And rarely, I'll just add it to complete the list, placental tumor, like a core angioma, can cause polyhydramnios. Okay, question किस पे आता है? Question very oftenly, all the anomalies cause poly except. So remember, any obstruction to fetal swallowing is going to cause polyhydramnios. And the opposite, any obstruction to urine production is going to cause oligohydramnios. Patient will be very uncomfortable. Okay, she'll have a large abdomen. She'll have respiratory discomfort. She'll be very uncomfortable. Inspection, there will be a shiny, stretched skin. Okay, the umbilicus may be everted. On palpation, you can't, unable to palpate. I can't palpate the fetal parts and the fetal heart rate is muffled or very, very faint. Okay, so this is on auscultation. Oligohydramnios, what are you going to find? AFI less than 5 or single vertical pocket less than 2 centimeters. Causes are very important. So causes, number one could be excessive loss of amniotic fluid. Maybe she has ruptured her membranes. Okay. Maybe there is less urine production. Why? Because of uteroplacental insufficiency. Okay, like in preeclampsia, what is happening? There is less blood flow to the baby, so less blood flow to the kidneys. Okay, and because of that, there is less urine production. So this leads to less fetal urine production. Then certain drugs like AC inhibitors, angiotensin receptor blockers, and lastly, anomalies, which are basically renal anomalies like renal agenesis or dysplastic or multicystic kidneys. Okay, or a bladder outlet obstruction like a posterior urethral valve. Okay, so urine is not being formed or urine is not being able to come out will lead to oligohydramnios. These are the causes of oligohydramnios. Next important topic is antepartum hemorrhage. Again, a question is going to come from antepartum hemorrhage. Remember, obstetric emergencies is going to be very, 2, 3 questions are going to come from here. What are obstetric emergencies? Postpartum hemorrhage, antepartum hemorrhage, okay, eclampsia, severe preeclampsia, HELP syndrome, so hypertensive disorders. Okay, what else? You can have from shoulder dystocia, cord prolapse, okay, retained placenta, placental inversion, okay, amniotic fluid embolism. So other basically third stage complications apart from PPH. So questions come from here because you are expected to know basic management of obstetric emergencies. So it's a given कि यहाँ से question आना ही आना है. Now let's start with one of them, that is antepartum hemorrhage. Now we know antepartum hemorrhage primarily abruption या placenta previa. We have to differentiate between both of these. What is abruption? Abruption is premature separation of a normally implanted placenta. That means placenta has come away from its normal place. Normally कब होता है placental separation? In the third stage of labor. If it's happening any time before, it's called as anti-abruptio placenta. What is placenta previa? Placenta previa means a low-lying placenta. Placenta in the lower uterine segment. Okay, so this is, let's start with placenta previa. This is placenta previa. This is normal. This is placenta previa. Obviously this will bleed, है ना? So what is the classical presentation? Is painless, recurrent vaginal bleeding after 28 weeks of pregnancy. So painless, recurrent vaginal bleeding after 28 weeks of pregnancy is how this patient will present. Abruption will be painful. That's the first important difference. तो जहां आपको पेन दिख रहा है, that is abruption. जहां painless है, that is placenta previa. That's one of the most important differentiating features. Also, there may be a clue in your question. History of IVF pregnancy. History of multiple pregnancy. That means twins, triplets. History of a cesarean section or any scar on the uterus. Placenta tends to go in that part of the uterus. ठीक है? और history of cesarean section है तो एक और चीज हमें सोचना, what else should we think of? We should also think of placenta accrete syndromes. Okay, that is PAS, placenta accrete syndromes. Okay, are whenever you get a patient with placenta previa with a history of a cesarean section, always rule out placenta accrete syndromes. ये क्या होता है? ये होता है morbidly adherent placenta. So placenta accreta, placenta increta, placenta percreta, you should start thinking of. Okay, what else? If there is a history of elderly woman or grand multipara, so grand multipara is an important history. and if her age is more than 35 years. These are some important risk factors which may give you a clue that this might be placenta previa. Again, very important classification. This is the older classification. Ab hum use nahi karte hain, but you should know it because questions come on this. So if the placenta is in the lower segment but not reaching the os, can you see it's here, but it's not reaching the os? This is a type 1 placenta previa. Second picture, it's reaching the os but not covering it. This is type 2. इसको further हम divide कर सकते हैं anterior and posterior. ठीक है, आगे की तरफ है तो type 2A, पीछे की तरफ है type 2B, posterior. This is the third type. This is type 3. It's covering the os but partially. So here it's touching the os. Here it is partially covering the os. I think I said it by mistake. This type 2 is touching the os. Type 3 is partially covering the os and type 4 is completely covering the os. Okay, so this is the older classification. Type 1 is not touching the os but in the lower segment. Type 2 is touching the os. Type 3 is partially covering. Type 4 is completely covering the os. This is the older classification, what is called as Brown's classification. But now we use the newer classification based on a transvaginal scan. Remember, TVS is safe in placenta previa, okay? But it's not routinely done, but this is the newer classification. That they're just two. A true placenta previa means it is covering the os. True placenta previa means covering the os, partially, complete, everything. Covering the os means true. And low-lying placenta means the lower edge is less than 2.5 centimeter from the os. But it's not covering the os, it's just within this circumference. Okay, so this is the newer classification based on a transvaginal scan. True placenta previa and low-lying placenta. Now, as I said, placenta previa, remember, is a clinical sorry, what am I saying? Sorry, just erase that. Placenta previa will present as recurrent episodes of painless vaginal bleeding and diagnosis is on ultrasound. So you have to do an ultrasound to diagnose placenta previa. We usually do a trans-abdominal scan. Remember, never ever do a per vaginal examination if you're suspecting placenta previa, because if you poke your finger inside the cervix, she may start bleeding torrentially. Also remember, placenta previa can be managed expectantly or we deliver her. There are two ways. Either you deliver her or you wait. Okay. Now, when do we deliver her? If she is more than 37 weeks, there is no point waiting. You're simply putting her at risk of another bleeding episode. So if she's crossed 37 weeks, deliver her. And how will you deliver her? By a cesarean section. This is the safest way to deliver a placenta previa, type 1 and type 2A. These two, you can try a normal delivery, type 1 and type 2A. Okay, these are minor types of placenta previa. All the rest are major types. But even in the minor types, many times they will invariably bleed as the cervix dilates. So usually cesarean section is required. Now, when do you do an expectant management? Expectant management means McAfee Johnson management. Okay, McAfee Johnson management is done if the patient is less than 37 weeks. Okay, and so all of them are and all four criteria should be met. And the mother is stable. That means her pulse and blood pressure are all right. The fetal heart rate is normal. Okay, and there is no active bleeding. So she comes with an episode of bleeding, but jab tak wo hospital aa gaya, bleeding has stopped. Vital signs are given to be stable. Fetal heart is 140 beats per minute and she is 33 weeks. You will give her expectant management. Expectant mein kya karoge? You will admit her. You will give her hematinics. That means increase her hemoglobin. You might have to give blood transfusion also. Okay. And give her steroids. Okay, if she is less than 34 weeks. What steroid do we give? We can give dexamethasone or betamethasone, and this is for fetal lung maturity, because in case she has another bout of bleeding after 2 days, and which is continuous, doesn't stop, or she goes into shock, you have at least given her steroids so that the fetal lung maturity is attained. So this is how you manage placenta previa. There is a role of expectant management. Unlike abruption, remember abruption is an emergency. Both are emergencies, but placental abruption has to be delivered immediately. Remember, there is no role for expectant management in abruption. That's one of the major differences. Also remember painful. It's painful. So painful bleeding is abruption. Okay. Also remember it is a clinical diagnosis. That means you will do a scan just to rule out placenta previa. There are no clear-cut findings on the scan for abruption. You're just doing it to rule out placenta previa. So painful bleeding, also 50% of patients, there will be a history of hypertension. So preeclampsia will be there. Remember, I told you APLA is associated with abruption and preeclampsia. So hypertension, painful bleeding is abruption. So this is abruption. You can see here the blood, the placenta has separated. This is called a revealed abruption, where the blood is all coming out, or the blood keeps collecting inside. This is called a concealed abruption. Okay. So how will this patient present? Painful, or both of them actually. Painful bleeding, but in concealed, the pain will be more. Okay, when you examine this patient, you will find a tense, tender uterus. These are buzzwords for abruption. Placenta previa में ऐसा कुछ नहीं होगा. The uterus will be soft, normal, non-tense, non-tender. But in abruption, the abdomen will be tense and tender. Okay, because of all this blood collecting inside, and the fetal heart is usually absent, or there is fetal distress. So because the placenta is coming out from its place, the baby is unable to get blood supply, so there will be fetal distress usually, or the fetus may have died. So remember, abruption is an acute situation, okay, where unless you take the baby out quickly, you will lose both the baby and the mother also. Risk factors, remember hypertension, okay. Other risk factors, remember APLA. Other risk factors, remember smoking. This is also a risk factor for placenta previa also. Also remember polyhydramnios. Okay, when you're doing an ARM, artificial rupture of membranes in a woman with polyhydramnios, this is how your clinical question can come. The patient, as I told you, has sudden bleeding or blood-stained liquor and fetal distress. What is your diagnosis? Blunt trauma to the abdomen. Okay, these are all risk factors for abruption. So as I said, fetal complications, fetal distress and death is very common. Maternal also, because of all this bleeding and concealed abruption, the blood keeps collecting inside. The mother quickly goes into DIC. In fact, the most common obstetric cause of DIC is abruption. Okay. She can also have renal failure. She can also have postpartum hemorrhage, and she can also die. Okay, so these are the problems the mother can have. So abruption, you can really realize, is a much more acute situation. That's why you're going to diagnosis we've dealt with. It's clinical. This I've told you, concealed versus revealed. So management is deliver. Immediate delivery is the rule. Of course, your emergency measures, resuscitation, blood transfusion, all that will go hand in hand. But immediate delivery is the rule, irrespective of period of gestation. She may be just 28 weeks. Okay, you're not going to waste time giving steroids. Okay, you're going to deliver her immediately, because the baby might be dead already. The baby might be distressed. You have to take out that baby by the quickest way possible. Okay, so if the baby is distressed or the mother is in shock, the quickest ways to be used, that is a cesarean delivery, is usually the quickest way. If you find fetal heart rate is 60, 70, 80, 90, or the mother is in shock, there's no point waiting for a normal delivery. But if it's mild abruption, that means no fetal distress. Or suppose the fetus has died already and the patient might already be in labor, then you can augment labor and have a vaginal delivery. But every case has to be individualized. In other words, cesarean section is done for most patients, but again, it is not the rule. What is the rule? Immediate delivery by the quickest way possible. Okay, and many times we end up doing a cesarean section to save the baby or the mother or both. Okay, so this is abruption. Image based question. This is a patient जिसका cesarean हो चुका है. This was a patient of abruption. Cesarean done. And now if you look at the uterus, you see this bluish. Normally a uterus should be pink in color following delivery or even in a pregnant uterus. This bluish stains should not be there. This is a concealed abruption. Okay, where the blood has seeped inside the myometrium and it's given this bluish color. So if you see this, if you get an image-based question like this, what are you going to do? Somebody's raising their hand, Shubham, I think raised hand. Shubham, just drop me a message separately because I don't want to spoil the tone of the class. Okay, and I have written, if you go scroll back, you'll find my number if you don't have my number. Okay, Kuvaler, on the chat box, you'll find my number. For those all who are joining later, if you have a doubt in this class, just jot it down and message me at night. I'll be sitting on my WhatsApp and solving all your doubts. If you're a member of any of the groups, write your doubt there or message me separately. Today I'll be answering all the doubts. Okay. Okay, give me a thumbs up if that's okay, or a thumbs down if it's not okay. Okay. Okay, thank you everybody. Thank you. Okay, so image-based question. What will you do if you see this? What are you going to do? You're not going to do anything. You're just leaving her alone. Uterus is contracted, PPH nahi ho raha. This is just an incidental finding. It's just a finding. You're not going to act upon this. You're not going to remove the uterus. The blood which has seeped into the myometrium will, after some time, it will get absorbed by itself. Okay. Now, important points in multiple pregnancy. Remember the classification and the chorionicity. That is what we're going to deal with. There are two main types, monozygotic and dizygotic twins. Monozygotic is one sperm fuses one ova and forms an embryo, and this embryo splits into two babies. Okay, so this is a monozygotic twin. Dizygotic में क्या हो रहा है? Two separate sperms are fusing two separate ovas and two separate embryos have formed. So this is dizygotic. Dizygotic is what you see when you do an IVF pregnancy. Because IVF में हम we're making the embryos separately outside and then putting them back inside the uterus. Okay. Or what you see after ovulation induction. If two follicles are released, two eggs are released, they are fertilized by two sperm. So two separate embryos with different genetic material are formed. So remember dizygotic, because they are two embryos, they form their own amniotic cavity, they form their own placenta. So dizygotic twins are always diamniotic, dichorionic. They are always diamniotic, dichorionic. Okay, there is no doubt here. Dizygotic twins are completely separate embryos. So they have their own amniotic cavity, their own placenta. ठीक है, placenta का मतलब chorion, amniotic cavity का मतलब amnion. The problem comes here. In monozygotic twins, this which has split into two embryos, same genetic material. Okay. Now, depending on when the splitting happens, different things happen. So if the splitting happens within 72 hours, within 3 days, what is happening? Each embryo has formed separately, okay? And each forms its own amniotic cavity and its own placenta. So it forms again diamniotic, dichorionic twins. Because splitting बहुत जल्दी हो गया, each has formed its own amnion, its own chorion. सेकेंड सिनेरियो है कि स्प्लिटिंग थोड़ा लेट हुआ, 4th to 8th डे में हुआ. सो बाय देन व्हाट हैज हैपेंड, द प्लेसेंटा हैज फॉर्म्ड, ओके, बट ईच embryo has formed its own amniotic cavity. So what has happened? This is a monochorionic diamniotic twin. मतलब placenta एक है because placenta form हो गया था, then the splitting happened. So monochorionic diamniotic. Now the splitting has happened little later, 9th to 12th day. What has happened? Chorion has formed, amnion has formed, and only the babies are separate. So that means this is a monochorionic monoamniotic twin. Okay, that means they have a common placenta. They're even in the same amniotic cavity. There's nothing separating them. Okay, and this is MCMA. And the last type is when the splitting happens after the 12th day. What happens? The embryos also are somewhere joined. The splitting of the embryo is also incomplete. So there are type of MCMA twins which are called as conjoined twin. So you may get a question, conjoined twin is a type of DCDA, MCDA or MCMA. Conjoined twins are monochorionic, monoamniotic. Okay. Now also remember that this is the most common. Dizygotic is the most common. More than 60% are dizygotic, 30% are monozygotic. Dizygotic में भी DCDA सबसे common है, ठीक है? Rare वाले हैं ये वाले. Okay. These are the rare ones. Okay. Now, in these rare ones, we are worried about whenever there's a common placenta, there's going to be sharing of the vessels. Okay. And that's going to cause problems. So remember, MCDA वाले सबसे खतरनाक होते हैं और उससे भी ज्यादा MCMA खतरनाक होता है, ठीक है? Now, diagnosis and chorionicity, so this determination कि कौन सा placent, कौन सा type of chorionicity है, is it dichorionic, monochorionic, ठीक है, is best told to, so if we know about this in the antepartum period, we are more careful, we know to expect complications. See, so on ultrasound, स्पेशली एट 11 to 14 वीक्स. सो 11 to 14 वीक्स बहुत इंपॉर्टेंट हो गया. क्यों? क्योंकि लेवल 1 स्कैन है, एनटी स्कैन हम कर रहे हैं. और क्या देखा हमने? सर्वाइकल लेंथ देखा. और क्या देख रहे हैं हम? कोरियोनिसिटी ऑफ ट्विंस देख रहे हैं. और क्या देखेंगे? अभी हम पढ़ेंगे स्क्रीनिंग ऑफ प्री एक्लैम्प्सिया भी करेंगे, ठीक है? सो इट्स अ वेरी वेरी इंपॉर्टेंट स्कैन, द लेवल 1 स्कैन. ओके, so on ultrasound we are seeing the chorionicity, and in how do we basically see, ये तो हम इंडिया में करते नहीं, we don't see the fetal gender. Okay, so this is out for us, ठीक है? We can either see the number of placentas. If we're seeing 2 placentas, we know that it is dichorionic. Okay, but what happens actually, there's so much less space in the uterus that even 2 placentas appear as one. You can't actually make out because space is very less. So what is the major thing we are seeing is this intervening membrane. ये जो है, ये वाला part, ये हमें देखना है, ठीक है? So in this, there is no intervening membrane in MCMA. So it's very easy to diagnose MCMA. There is no intervening membrane. प्रॉब्लम कहाँ आएगी? इन दोनों में आएगी, DCDA और MCDA में, because दोनों में there is a intervening membrane. And that is why this slide is very, very important. Okay. Now look at the first one. Can you see this intervening membrane here? And can you see how thin it is? Okay. So see how this is the placenta. This is the intervening membrane. This is fetus 1 and this is fetus 2. Okay. So if you look here, this is what it is. This is basically a monochorionic diamniotic twin, right? This is amniotic membrane of one twin, amniotic membrane of other twin. One baby is here, one baby is here. And they're sharing a placenta. So this junction is what we are seeing. This junction is what we are seeing. This is called a inverted T sign or a reverse T sign, okay, which is seen in MCDA twins. As against ये वाला, ठीक है, ये fetus A, ये fetus B है, यहाँ पे कहीं पे placenta है, so you can't make out one placenta or 2 placenta, but this is the intervening membrane and you can see it's quite thick. Why is it thick? Because it has the amniotic membrane of one twin, the placenta of one twin, the placenta of the other twin, and the amniotic membrane of the other twin. Okay, so it's a thicker intervening membrane. This is called a lambda sign or a twin peak sign. And this is seen in dichorionic, diamniotic twins. Okay, so this is how on ultrasound we differentiate between MCDA and DCDA. MCDA में है आपका inverted T या reverse T या simply T sign भी कहते हैं इसको, ठीक है। और ट्विन पीक मतलब बड़ा सा पीक है। बड़ा सा पीक क्यों है? क्योंकि दो प्लेसेंटा है, दो amniotic cavity membranes है, so it's obviously appearing thicker. Okay, so this is very, very important. Vanishing twin and fetus papyraceous. What is this? Vanishing twin is when on scan the patient comes and you give her the good news that there are two babies. When she comes at 12 weeks, you say only one baby. So this is called a vanishing twin. That means abortion of one twin, of one baby, okay, in the first trimester. And the patient may not have any symptoms. She may have spotting, but it's so small, the fetus वो अपने आप ही अंदर absorb हो जाता है. So many times the patient doesn't have symptoms, it's just vanished on the ultrasound. Fetus papyraceous क्या है? Fetus papyraceous is, papyraceous in Greek means paper-like. Okay, so flattened, patla sa, paper-like. ठीक है? And this is seen in the second trimester of pregnancy if one baby dies. So fetal demise of one twin in the second trimester is called as fetus papyraceous. Okay. So what happens if you look carefully, this is the live twin baby who was born and ये दिख रहा है, ये placenta के साथ compress होके, this is the second twin. Okay, so it's diagnosed many times at delivery. You see that you find a fetus-like compressed structure at the placenta. This is called fetus papyraceous. It can come as an image-based question. Okay. Very important, which comes as a question, is TTTS. What is TTTS? Remember, it is seen in MCDA twins, monochorionic diamniotic. They're sharing a placenta. Okay, if they're sharing a placenta, vessels might be shared also. So what is happening? One baby is getting more blood. Okay, and one baby, and who is giving that baby more blood? The other baby. So one twin becomes a donor twin. It donates blood, and the other twin becomes a recipient twin. It receives blood. Okay, so the donor twin becomes anemic. The recipient twin becomes polycythemic. The donor twin will have oligohydramnios because anemia hoga, तो renal blood flow कम होगा. So renal production, basically it will go into anuria. And there'll be oligohydramnios, eventually fetal death because of receiving less blood. And polycythemic twin को क्या होगा? Polyhydramnios हो जाएगा and it will have cardiac overload. Eventually this will also die. Okay, because of cardiac failure. ठीक है? So what should you know now? What should you know about TTTS? Number one, it is seen in MCDA twins. Number two, it is called as oligopoly sequence because एक में oligo है, एक में poly है. So this is what is happening. Okay. So it is seen in MCDA twins. It is called as oligopoly sequence. Number three, you should know that the staging is called as, there are different, there are 5 stages. You don't need to know the stages. Just remember the name. Quintero staging is used to stage the grade of TTTS. And the fourth important point is the treatment. What will you do to treat this? So this anastomotic vessel here has to be ablated. And the best way to do it is a laser ablation of the anastomotic vessel. Okay, so you put a fetoscope inside. So it's done by fetal medicine specialists. A fetoscope is put inside like a laparoscope. You put a fetoscope inside the uterus and look at this anastomotic vessel and fire a laser here and coagulate this. So remember these important points for TTTS. Okay, there's another rare complication, not important, but I'm just putting it here, called the trap sequence. Twin reversed arterial perfusion. इसमें क्या होता है? एक twin, एक cardiac है. One twin doesn't have a heart. Okay, so same thing is happening like TTTS, because one twin doesn't have a heart. One twin is just pumping blood to that A cardiac twin. This is the A cardiac twin. So this twin is going to become anemic. Okay, and what are we going to do here? This twin is anyway not going to survive. It doesn't have a heart. So what do? We just ablate in utero. We ablate the umbilical cord of that twin. But basically, we sort of detach this twin from the placenta completely. Okay, there's no point looking for the anastomotic vessel because you know this twin is not going to survive. Just ablate the umbilical cord, and this baby will eventually, of course, it's anyway doesn't have a heart, it's not going to survive. Okay, so a cardiac twin, you will do ablation of the umbilical cord. That's all you need to remember. Monoamniotic में क्या हो रहा है? There is no intervening membrane. They are both lying in the same sac. So when they move around, what is going to happen? There's a very high incidence of cord entanglement. That means the cords get tied up. There are knots in the cord, and the blood supply of one or both twins gets cut off. So there's a very high incidence of intrauterine death. इसलिए in MCMA twins, monochorionic, monoamniotic, what are you going to do? You're going to do a planned elective cesarean section when at 34 weeks. You're not going to wait because the more you wait, the more these babies can die in utero. So you do elective cesarean. Cesarean ही करोगे इसमें, no trying a normal delivery. Elective cesarean at 34 weeks is the rule for MCMA because of a high risk of cord entanglement. Conjoined twins will look like this. What do you get questions here? The most common type is a thoracophagus. That means they're joined at the chest region. Again, if you diagnose conjoined twins at term, no role for normal delivery, even though they may not survive, you will directly do a cesarean section because you'll end up with obstructed labor otherwise. So cesarean section is the rule. Okay, so when we talk about management of twin pregnancy, what is important is this: the indications for elective LSCS in multiple pregnancy. Well, kisme you will not even think of a normal delivery. You will directly do in an elective cesarean section if number one, the first twin is non-cephalic. What does this mean? If the first twin is breech or transverse lie. So what matters most in deciding the mode of delivery is the first twin. If both are cephalic, you can allow. If one is cephalic and the second is transverse, you can allow normal delivery. If the first is cephalic and the second is breech, you can allow normal delivery. Okay. But if the first is a breech, irrespective of the second, you will do a cesarean section. Or if the first is a transverse lie, you will directly do a cesarean section. So first twin breech, transverse lie, direct cesarean. Triplets and above, direct cesarean. Conjoined twins, direct cesarean. Monoamniotic twins, direct cesarean. And what is discordancy? Discordancy का मतलब है one twin small, one twin big. That means fetal growth restriction of one twin. You will again directly do a cesarean section. This is called as discordant twins. Okay, so the best way to predict the future is to create it, and that is what we are doing right now. Okay, so what's the time? I haven't seen the time. How much time do we have? Okay, just give me a second. Just give me a second. Huh? All right. Okay. So let's continue. Now, fetal growth restriction, what are the important points you should know? That the umbilical artery Doppler is going to decide the role of decide the management. Okay, so we won't discuss what is FGR, what are the types, all that is not important. How will you decide how to manage fetal growth restriction? What is FGR? It is also called as IUGR. That means the baby is small. It is less than the weight is less than the 10th percentile of that, what it should be. Okay, so if you have a FGR or IUGR baby, the first thing you will see is the umbilical artery Doppler. Now look at this image. This is a normal umbilical artery Doppler. So if you get this image, you are not worried. Okay, so in this image, you will continue doing Dopplers every 2 weekly till 37 weeks and then deliver. Okay. But what happens as the blood flow to the baby gets more and more restricted? You can see that the diastole keeps coming less. So you have this part, which is the systole. Okay, this is the systole and this part is the diastole. So what happens as more and more blood is flowing less to the baby, the diastole keeps coming down. Okay, can you see here the diastole is more and here it is very, very less. Eventually what's going to happen, it's going to become absent. Can you see here there is no diastolic flow. So this is called as absent end diastolic flow. When you see this on the ultrasound, you know that you have to deliver this baby. If she is more than 34 weeks, deliver immediately. If she is less than 34 weeks, give her steroids and then deliver. So absent end diastolic flow is an indication for delivery. More than 34 weeks, immediately deliver her. Less than 34 weeks, give her steroids and then deliver her. What happens if nothing is done at this stage? This flow is going to get reversed. Can you see the diastole has actually gone on the other side of the baseline? This is called a reversal of end diastolic flow. So both absence and reversal are indications for delivery. Same thing, after 34 weeks, deliver. Less than 34 weeks, give steroids and then deliver. How will you deliver? Usually these babies are already hypoxic because of less blood flow. They don't withstand, many of them will not withstand normal delivery. So usually a better option if you're given in the exam, a cesarean section is usually better for such babies because they are not going to able to withstand the contractions. So when to deliver, this is decided by your umbilical artery Doppler. If all is well, if it is normal, 37 weeks. But absent or reversal, you deliver ASAP. Okay. How to deliver? I told you absent or reversal, you will prefer a cesarean section. Okay. So this is the flowchart for FGR. It's very simple. History and examination, your fundal height, uterine height will tell you whether this is FGR. This is your clinical diagnosis. Okay, how will you confirm? You will do an ultrasound where you're going to see 4 parameters: the biparietal diameter, the head circumference, the femur length, the abdominal circumference. All these will give you an estimated fetal weight. The ultrasound, the software will calculate and tell you an EFW. The software will also tell you whether that EFW is less than the 10th percentile for that gestational age. Okay. For example, at 34 weeks, we usually expect the baby to be around at least 2 kg. This is just an example. Okay, so if it's say 1.2 kg, you know it is significantly, or 1.5 kg also is significantly small at 34 weeks. So if you've diagnosed on ultrasound FGR, you're going to do an umbilical artery Doppler. Okay, now if this is normal, you'll keep doing the umbilical Doppler every 2 weeks and you will plan her delivery at 37 weeks. But at any time, if the diastole reduces, it's not absent or reverse, it just reduces. You increase your frequency of Dopplers, you do it twice a week and you plan delivery at 37 weeks or earlier maybe if there is no growth in 3 weeks. But if there is absence or reversal, planned delivery if more than 34 weeks, or if less than 34 weeks, give steroids and then plan delivery. So it's a very simple flowchart, but important to understand is this part. कि delivery कब करोगे? Delivery करोगे अगर absent या reversal of flow, and कौन सा Doppler? Umbilical artery Doppler. These two are very, very important. Okay. And if all is fine, you will still deliver at 37 weeks. You won't let her go beyond, because you know that the intrauterine atmosphere is not good. That's why the baby is not gaining weight. Important points in preterm labor. First is definition. What is preterm labor? If delivery is happening before 37 weeks, we usually take if you're in a developed country, the lowermost limit is 24 weeks. Okay, in India, we would take 28. In not again, I wouldn't generalize, in most places in India. Okay, so this is your definition of preterm labor. If the patient goes into labor between 24 to 37 weeks. Term क्या होता है? This is term. 37 to 42 weeks के बीच में को term कहते हैं. 42 weeks के बाद हम कहेंगे post term. Okay, so this is very important. Now preterm you can further subdivide. 24 to 28 weeks is called as extremely preterm. 28 to 32 is called as very preterm. 32 to 34 is called as moderate preterm, and 34 to 37 is called as late preterm. Okay, so extreme, very, moderate, late. This is how you further subclassify preterm labor, and this is what you should know. Term is 37 to 42, beyond 42 is post-term. So diagnosis, this comes as a question. How will you diagnose preterm labor? Regular contractions before 37 weeks associated with cervical change. So on abdominal examination, you will find uterine contractions more than or equal to 2 contractions in 10 minutes should be there to diagnose preterm labor. With on PS or PV, if the cervix is more than or equal to 1 centimeter dilated or more than or equal to 80% effaced. Effaced का मतलब है it is thinned out. The cervix is thinned out. So contractions plus cervical changes is called as preterm labor. So both should be there. Contractions and cervical changes is called as preterm labor. Okay. Now remember we talked about cervical length measurement. This is the cervical length measurement. I was talking about this measurement. Okay. It is not only a predictor for cervical insufficiency, it is also a predictor for preterm labor. Same thing, less than 25 millimeter before 24 weeks. Okay. Remember, less than 24 weeks is a predictor for preterm labor. And if the patient is at risk for preterm labor, we can give her progesterone, we can give her vaginal progesterone or oral progesterone or intramuscular progesterone. Okay, or we can even do a cervical cerclage. So remember, cervical cerclage, जो cervical insufficiency है ना? On one spectrum, you have very early deliveries happening. Okay, but थोड़ा बहुत cervical insufficiency है, patient can even present with recurrent preterm losses. So cervical cerclage can benefit a patient who has a history of preterm birth or mid-trimester loss and a short cervix. How do you manage preterm labor? Bed rest, hydration is understood. In utero transfer का मतलब क्या है? It's better to transfer the mother with the baby inside rather than deliver and then refer the baby. Okay, so in utero transfer is preferred. And while you're doing in utero transfer, you can give corticosteroids and you can give tocolysis. What is tocolysis? These are drugs that relax the uterus. So if you're shifting her from somewhere far off in the village and you're sending her to a higher center which has good neonatal care facilities, in that interim period, you're going to give her corticosteroids and tocolysis. Okay. So role of corticosteroids is basically given to reduce the incidence of respiratory distress syndrome in babies who are less than 34 weeks. Okay. Where do we give them? We give them in scenarios where delivery is she's less than 34 weeks, and delivery is expected within 7 days. Okay, so if you're planning to deliver her, say severe preeclampsia, you're planning to deliver her, or she's less than 34 weeks, or she is going into labor, then you can give steroids. So we give dexamethasone or betamethasone. Both can be given. If you're giving dexamethasone, you're giving 12 milligram, 2 doses intramuscular, 24 hours apart. If you're giving dexamethasone, you're giving 6 milligram, 4 doses, 12 hours apart, intramuscular. Okay, so this is the dose of dexa and betamethasone. Now coming to the different types of tocolytics. Tocolytics can be calcium channel blockers like nifedipine. This is the drug of choice. I'm just saying the important things that you need to know. The drug of choice for tocolysis is in a patient who's otherwise not having any medical disorder. Nifedipine is the drug of choice. Remember, nifedipine can cause flushing, sudden hypotension, okay, and tachycardia. We can also give, but we don't usually give, beta mimetics. These are beta agonistic drugs, but remember, they are not to be given in patients who have heart disease because they can cause tachycardia, hypotension, even pulmonary edema. They are also not to be given in patients with diabetes because they can cause hyperglycemia. So remember, beta agonists, especially beta 2 agonists, can cause uterine relaxation, but they are not the preferred agent because of a lot of side effects. Magnesium sulfate. Where else do we read about magnesium sulfate? So it is a tocolytic agent. It is also given in eclampsia. It is also given in severe preeclampsia, basically as to prevent eclampsia. Okay, and it is also given as a neuroprotective agent in preterm. So again, in preterm, babies who are born very preterm, less than 32 weeks, they increase risk of cerebral palsy and neurodevelopmental delay. So giving magnesium sulfate in preterm, mothers who are going in preterm labor, gives some neuroprotection to the baby. Okay. Atosiban is a very important drug. It is a newer drug. It doesn't have any side effects. So that's the best part. But it is very costly. That's the bad part. What is it actually? It is a oxytocin receptor antagonist. Okay. So that's that, and that's why we don't give it. It's such a good drug. It has no side effects, but it is so costly that no, you just can't give it. So it is, how does it act? It's an oxytocin receptor antagonist, and that is the mechanism of action. So you can get questions on this if the patient is heart disease, diabetic, over CCBs, over nifedipine, you will actually prefer atosiban if she is known heart disease or known diabetic. Then two other smaller groups you should know: nitric oxide donors, bas naam yaad rakh lo, and indomethacin. We discussed this already. What is the most important point about indomethacin? You should know that it is contraindicated after 32 weeks. Why? Because it causes premature closure of the ductus arteriosus, and the patient can have cardiac failure. The baby can have cardiac failure. Hence, we don't give this after 32 weeks. Very important topic: hypertension in pregnancy and hypertensive disorders. What should you know? You should know the definitions of preeclampsia and eclampsia. What is preeclampsia? Blood pressure more than or equal to 140/90 on 2 occasions, usually happening after 20 weeks of pregnancy, with proteinuria. So proteinuria is very important. Okay. In gestational hypertension, there is no proteinuria. Okay, so proteinuria, so we do a dipstick. If it's more than +1, it is significant proteinuria. Okay, but newer guidelines, some have come. ACOG American guidelines say now more than 2+. This is a recent change, but most of the other guidelines haven't changed. So you can still remember 1+, 2+ भी ठीक है ना? But basically proteinuria dipstick of more than 1+ is preeclampsia. Eclampsia क्या है? Preeclampsia plus seizures. Chronic hypertension क्या है? Chronic hypertension है patient is already hypertensive and she becomes pregnant. So a known hypertensive becomes pregnant, or a patient who was diagnosed to have maybe say gestational hypertension or preeclampsia, and the BP persists to be high even after 12 weeks postpartum. So then she becomes, retrospectively, she becomes chronic hypertensive. Okay. So this is what you should know. Okay. So, important question. What is the basic etiology? What is happening? So you have extravillous trophoblastic cells. Okay. So normally what's happening? This is a non-pregnant patient. This diagram is very, very important. Okay. That's why I'm showing it. So this is the spiral artery. देख रहे हो बहुत कम blood जाता है uterus को usually. So in pregnancy, what is happening? You have these cells here. These are the extravillous trophoblasts. They are coming from the decidua. They're invading the arteriole and they are making it nice and dilated. Okay, so this is called trophoblastic invasion of the spiral arteriole. And this happens in two waves. The first wave happens in the first trimester, and the second wave happens in the second trimester, usually around 18 to 20 weeks. Okay. Preeclampsia में क्या हो रहा है? थोड़ा बहुत dilatation हो रहा है, but it is incomplete. So incomplete trophoblastic invasion. Okay. Especially the second wave of trophoblastic invasion is deficient. And as a result, you have a relatively less blood flow going to the placenta. This triggers a lot of cytokine and inflammatory mediators are released, and it results in the entire sequelae of preeclampsia. Now, इससे हमें क्या सीखना है? What should we? This image is very important. You can directly get a question from this image, or you can get a question from predicting preeclampsia. So, knowing the pathophysiology, how can we know which patients are at risk of developing preeclampsia? So, this is where your question will come from. So, the first thing is risk factors based on history. On history, what are the important history? History of chronic hypertension. So if a woman is already hypertensive, she's very high risk of developing superimposed preeclampsia. If she has a history of APLA, if she has a history of chronic kidney disease, if she has a history of overt diabetes mellitus, and if she has a history of past preeclampsia, that means in the previous pregnancy also she had preeclampsia. So these put her at high risk of developing preeclampsia in the current pregnancy, APLA or SLE, both. Second is the mean arterial pressure. Okay. Third is the 11 to 14 week scan. What do we look here? We look at not the spiral arteriole. We can't see the spiral arteriole, but we can see the Doppler of the main artery. That is the uterine artery Doppler. और इसमें हम क्या देखेंगे? We'll see the resistance to flow. So if the resistance to flow is increased, that means there is a raised pulsatility index. PI का मतलब, just remember this term. PI, pulsatility index, indicates a resistance to flow. So if the PI is more than 1 of the uterine artery, this means a resistant flow in the uterine artery. So we're looking at this. And at the same time, we're doing some biochemical markers. You can remember placental growth factor and PAP-A are reduced in women who may develop preeclampsia. Okay, just remember these two. These are the two most important ones. Placental growth factor, the ones with P, PGF and PAP-A. तो ये सब चीजें हम एक सॉफ्टवेयर में डालते हैं, ठीक है? and the software will tell us कि patient is low risk or high risk. ठीक है, अगर high risk आता है, ठीक है, ये risk factors है तो automatically high risk हो गई है. ठीक है, तो any of the parameters or the entire software which tells us that high risk है, what should we do, what can we do to prevent preeclampsia, to prevent in fact early onset preeclampsia, we give the woman low dose aspirin, and we preferably start this before 16 weeks, ideally before 12 weeks जब हम ये कर रहे हैं 11 to 14 weeks. ठीक है, but ideally better before 16 weeks. Okay, because why do I want to start this before 16 weeks? Before the second wave of trophoblastic invasion is happening, we want to give low dose aspirin. This is going to help in the second wave of trophoblastic invasion. Okay, so this is the only known method to prevent preeclampsia. Okay. Now, when you get a clinical scenario of preeclampsia, the first thing you have to see कि ये non-severe है या severe है. There's no such thing as mild, moderate, severe. It is severe or it is non-severe. Some people call this mild, but it's actually not to be called mild. It is non-severe and it is severe. So if the BP is more than 160 by 110, it is severe preeclampsia. Proteinuria, remember, is no longer used to determine the severity. If there is headache, visual disturbances, epigastric pain, what are these telling you? These are telling you that this patient is going to throw a fit. तो अगर आपको ये exam में these things you're seeing, headache, blurring of vision, epigastric pain, what is the next best thing? You're going to give her magnesium sulfate because these are imminent signs of eclampsia. Patient आपके सामने बैठी है, question आ रहा है, you have to give her eclampsia. Can you switch on the light? Yeah, you have to give her magnesium sulfate to prevent eclampsia. So magnesium sulfate we give for treatment of eclampsia. We also give for prevention of eclampsia. Okay. Then if there is worsening renal parameters, it is severe preeclampsia. If there is thrombocytopenia less than 150,000 या 1.5 lakhs, if there is raised AST and ALT, ये क्या चीजें बता रहे हैं हमें? These are pointers towards HELP syndrome. What is HELP syndrome? H stands for hemolysis, EL is for elevated liver enzymes, and LP is low platelet count. So HELP syndrome itself is a sign of severe preeclampsia. If there is fetal growth restriction, if there is pulmonary edema, that means in your question, you're going to look for these features. अगर इनमें से कोई भी है, तो आपने क्या करना है? आपने इसको क्लासिफाई करना है as severe preeclampsia. Along with this, I'll also add eclampsia. नहीं है तो it is non-severe preeclampsia. That's the first thing you have to see if it is non-severe or severe. Okay, so how will you manage preeclampsia? If it is, so the definitive treatment is delivery. The pathology is in the placenta. जब तक आप delivery नहीं करोगे, this pathology won't go. So delivery is a definitive treatment. But when should you deliver her? If she is non-severe preeclampsia, you will deliver at 37 weeks. So if your question comes, look for 37 weeks as an option if it is non-severe. But if it is severe, you have to deliver her by 34 weeks. There's no point going beyond that because you're putting the mother and the fetus, you're subjecting them to more complications. तो severe है to 34, non-severe to 37, but severe में भी कुछ चीजें ऐसे हैं जो 34 तक भी wait नहीं कर सकते हैं. There's some indications where you may not be able to wait till even 34 weeks. What are those indications? Those are eclampsia. Eclampsia will not give you time at all. Eclampsia, even at 28 weeks, you will deliver immediately. Okay, if there is, patient is going into DIC, if the patient is having HELP syndrome, if the patient is having abruption, if the patient is having pulmonary edema. You will not be able to wait at all. Or if the patient is having fetal distress. Okay. Now in this, remember eclampsia and abruption, mein aapko, you won't even have time to give steroids. You will have to deliver ASAP. We've discussed abruption. Na, मैंने क्या बोला था? Deliver immediately. So if your patient is preeclampsia with abruption, deliver. Preeclampsia with eclampsia, deliver. Okay. Even in HELP syndrome, you won't have much time. You may have time to give one dose of steroids, but then you can't wait for 24 hours or 48 hours for your DEXA or beta to be complete. You will deliver. So consider termination earlier if any of these. Okay. And in non-severe, you can take her till 37 weeks. So non-severe deliver at 37 weeks, severe deliver at 34 weeks or earlier. Okay. Now, drugs which you can give in pregnancy, antihypertensive drugs. We usually start this if the blood pressure is going to be more than 160 by 110. Matlab severe preeclampsia may we start antihypertensive drugs. Alpha methyl dopa is safe. It used to be the drug of choice, but now the drug of choice is labetalol. Remember this. The drug of choice for preeclampsia in pregnancy is labetalol. You can give this as an oral tablet. You don't need to remember the dose. Not important at this time. If you don't know it, don't remember. It is the first line drug or the drug of choice. Okay. Nifedipine is also safe. So these three are the safe drugs, also along with hydralazine. These four drugs are safe in pregnancy. कौन सा नहीं देना है? ARBs, AC inhibitors are not to be given. Doses are not to be remembered. Just remember the drug of choice. Okay. This we've discussed. You are not going to give AC inhibitors or ARBs. In the second stage of labor, what are you going to do? Intrapartum management, preeclamptic patient in labor. What are you going to do? Number one, you're going to cut short the second stage of labor by either using a forceps or a vacuum. Okay, you don't want her to strain too much. जितना वो strain करेगी, उतना उसका BP बढ़ेगा. Withhold, very important, withhold methergin. What is methergin? It is a uterotonic like oxytocin, but in preeclampsia or eclampsia, we won't give this because it is also a vasoconstrictor. And by causing vasospasm, you're increasing the afterload and you're increasing the blood pressure further. So you won't give methergin. And you will restrict the fluid. You will not overload her with IV fluids. Again, you're going to push her into failure. So these 3 points are very important in a patient who is hypertensive in labor. Again, very important, eclampsia. Drug of choice you should know is magnesium sulfate. Okay. In eclampsia, seizure management is with magnesium sulfate. Along with that, you're going to bring her blood pressure down. How do we do that? The drug of choice, again, labetalol, but here we're giving IV labetalol. We're also giving, or you can give IV hydralazine. Either of these two drugs can be given. And at the same time, you are going to deliver her. Okay, so you're going to give magnesium sulfate plus antihypertensives plus plan her delivery. This is going to be your management of eclampsia. So magnesium sulfate, we all know it is given by Pritchard's regime. What is Pritchard's regime? You're giving a loading dose, okay, of 4 grams intravenous, 20% solution, plus 10 grams intramuscular, 50% solution. And then you're going to maintain this by giving on alternate buttocks every 4th hourly 5 grams intramuscular. Again, agar abhi tak dose yaad nahi hua hai abhi, it's not important to remember the dose. If you can, though, it may help. But agar lag raha hai nahi ho raha, chhod do. ठीक है, but remember the name Pritchard. Remember that there is a 14 gram loading dose followed by a maintenance dose, which is given till when? Kab tak dena hai? We give it till 24 hours after the last seizure or delivery, whichever is later. Matlab, suppose your question comes, patient had a seizure at 9 o'clock. She's eclampsia. She had a seizure at 9 o'clock and she delivered at 12 noon. Till when will you continue the magnesium sulfate? Answer is 12 noon. So whichever is later, the seizure or the delivery for 24 hours, whichever is later. Always check. This comes as a question. You will check if the patient is on magnesium sulfate, you are worried about magnesium toxicity. Okay. So you will check her deep tendon reflexes. You're going to check what else? You're going to check her respiratory rate and you're going to check her urine output. DTR is the first to disappear in magnesium toxicity. Respiratory rate depression ho jata hai. Respiratory rate will fall in magnesium toxicity. And output, why are we checking? Not because magnesium toxicity causes renal failure, because eclampsia can cause renal failure. And eclampsia जब renal failure cause करेगा, output कम हो जाएगा. Magnesium कैसे excrete होगा? Through the kidneys. So in a patient with renal failure and you're going on giving magnesium sulfate, the magnesium is not going to get excreted and your magnesium levels are going to go up. So you have to be very careful if you are giving magnesium sulfate in a patient who has renal failure. So very important. Okay. Okay. So remember, DTRs are the first to be lost. Again, you don't need to know the values, not important. Then respiratory depression, then cardiac arrest. What is the antidote if the patient is going into magnesium toxicity? The first thing you will do is you will check the magnesium levels. Okay. And then you will correct it by giving calcium gluconate. So 10%, 10 ml over 3 minutes. Remember, calcium gluconate and magnesium levels are checked if there is renal dysfunction or if there are signs of magnesium toxicity. So if your question comes that DTRs are not seen, what will you do next? Next is you will check for signs of magnesium toxicity and you will give calcium gluconate if there are signs of magnesium toxicity. Obstetric management, I already told you, expedite delivery, but zaruri nahi hai ki cesarean section hi karna hai. You will actually prefer a vaginal delivery, especially if the Bishop score is favorable. Okay, but if she has HELP syndrome, you might require platelet transfusion and same thing, avoid fluid overload. So nothing special here, but ऐसा नहीं कि सबका हम cesarean करेंगे. Okay, HELP syndrome, hemolysis, elevated liver enzymes, low platelet count. How do we know hemolysis is happening? Your question will give you that there is slightly raised bilirubin, LDH is high, more than 600, or features of hemolysis on the peripheral blood smear. AST, ALT more than 40 is abnormal, platelet less than 1.5 lakhs is abnormal. Okay. Now, diabetes in pregnancy, just one slide I made, which is important. GDM is gestational diabetes mellitus and pre-gestational diabetes is overt diabetes. इसका क्या मतलब है? इसका मतलब है patient was already diabetic and she has conceived. GDM का मतलब है कि pregnancy के time she has developed diabetes and this usually happens after 20 weeks of pregnancy. If you're getting diabetes less than 20 weeks, it is most likely to be pre-gestational diabetes. Okay. How do you diagnose GDM? By doing a OGTT at 24 to 28 weeks. This could be the IADPSG wala or the DIPSI wala. DIPSI wala is more commonly done in India. The cutoff value is 140. So 75 gram glucose we give. And if the value is more than 140 after 2 hours, it is called as GDM. Now in GDM, remember, because 20 weeks ke baad ho raha hai, so anomalies, abortions, all these things are not seen. Whereas anomalies and abortions are common in pre-gestational. They are not common in gestational because it's happening only after 20 weeks. Okay. Ketosis is uncommon here. Here, ketosis is more common. Okay, no end organ complications, but here you will have nephropathy, retinopathy, preeclampsia, fetal growth restriction, more common because you have vasculopathy. Here, in fact, you'll see macrosomia and polyhydramnios because baby is getting more hyperglycemic. So macrosomia, polyhydramnios, here you'll see fetal growth restriction. Here you treat this by diet, exercise, oral hypoglycemic agents, but pre-gestational, usually insulin is required in such patients. Okay, so this is basically the difference between GDM and pre-gestational. Pre-gestational, if the patient doesn't know her diabetic status, in the first trimester, we always check either by an HbA1c or a fasting in the first trimester. But GDM, we diagnose between 24 to 28 weeks. Okay. Now, infections in pregnancy are important, and then we quickly move on to the important labor topics. Okay, just a second. Okay, so yeah, it is 7:40. We have an hour. We will finish this, and I think labor would be good uh, to do in 1 hour. Okay, so varicella क्या होता है? Varicella होता है chicken pox. Okay, now what are we worried about with chickenpox? We're worried about congenital varicella syndrome. Okay, and this, the highest risk is if the woman develops chickenpox between 13 to 20 weeks of pregnancy. Matlab second trimester mein, the baby, the fetus can develop congenital varicella syndrome. Okay, now two types of questions can come on this. Okay, one is that the mother has been exposed to the virus. Commonly, the mother is a school teacher. She's 12 weeks pregnant. Okay, this is a favorite question of all the examiners. School teacher, 12 weeks pregnant, उसके क्लास में किसी बच्चे को चिकन पॉक्स हो गया. ठीक है? And she comes to you and she says that bacha came for 2 days to school and I've been exposed. I'm very worried. What should I do? Okay, so that's the most common scenario. And clinically also, this is the most common scenario. Pregnant school teacher comes with history of chickenpox exposure. Very, very common scenario. Okay, so what will you do? Okay, you will first ask her कि बचपन में कभी chickenpox हुआ है या नहीं. So you'll ask her childhood history of chickenpox. Many women will say कि हाँ हुआ था. Then you just reassure her कि then nothing to worry. Okay. But if she doesn't remember or she doesn't know, what will you do? You will get an IgG varicella done. You'll send a blood sample. एक दिन में report आ जाएगा. This will tell you if it's positive or negative. If it is positive, again, you will reassure her. That means you are immunized, nothing to worry. But if it is negative, that means she is not immune and she is at risk of developing chickenpox, especially because usko exposure bhi hua hai. So now you will give her varicella zoster immunoglobulin. Okay, preferably within 10 days of exposure. तो पहला question ऐसे आता है. So the question that will come is वही school teacher वाला comes very worried what to do. The answer is get a IgG varicella done. Okay. Now, second question. She's come to you. She's same school teacher has come with an infection. Okay. What will you do? She's come with an infection. You're going to. She has the typical rash of chickenpox. She has fever. What are you going to do? Now that she's got the infection, you can't do anything. You give her acyclovir and explain to her the risk of her baby having congenital varicella syndrome. क्वेश्चन इस पे नहीं आता. क्वेश्चन आता है टर्म पेशेंट पे. पेशेंट इज टर्म विद chicken pox, active chicken pox. 38 weeks primary gravida with chicken pox presents to your OPD or to the emergency. What is the next best step? Answer will be immediately deliver her or don't deliver her. Answer will be don't deliver her. Okay, as long as she's having active rash, delay delivery if possible. Why? Because in the active period, till the rashes don't crust over, antibodies haven't developed. So baby ko bhi antibodies nahi milenge. So if that baby is born without antibodies, that baby is at very high risk of neonatal varicella. ठीक है. So answer simple. Term with chickenpox, delay delivery. And exposure है to find out her exposure, her immune status. Is she immune or is she not immune? These are the two questions that come in varicella. Rubella, we've already discussed. The main question is immunization. Extremely teratogenic in the first trimester. Okay, so if a patient develops rubella, not immunization, rubella infection hota in first trimester, she should be advised an MTP. Okay, but immunization ke baad if she get conceives, doesn't require an MTP because thoda theoretical risk hai na? Classical triad of Gregg, what is it? The three C's, hai na? Cataract, congenital heart disease, and cochlea, sensory neural hearing loss. Okay. Then CMV. CMV में क्या important है? This word. When you see periventricular calcification, okay, think of CMV. So calcification, CC. Think of this. Remember, it also has a very high rate of fetal infection, and here also you can offer MTP. Okay, this is important. Herpes में क्या important है? Herpes में antenatal transmission risk is less. You're more worried about what risk? You're more worried about intrapartum transmission. That means transmission during labor. Because if she has these, so this is your buzzword to diagnose herpes. Painful vesicular genital lesions. If this is given, it means she has herpes. And when she has these genital lesions, इसमें viral load बहुत high है. So if the baby comes in contact with them during delivery, baby will have neonatal herpes. Okay, so you want to avoid this transmission. Hence, if your question comes of herpes in term pregnancy, you will directly advise an elective cesarean section. So elective section in active herpes at term is the rule. herpes में ये important है. Syphilis में क्या important है? ये वाला sentence. What is this? This is gradually improving obstetric history. So classical history will come. Patient had an abortion. This is a 5th pregnancy. First was an abortion. Second was a stillbirth. Third was a neonatal death with features of congenital syphilis. So that's how it is. Improving outcome is seen in congenital syphilis. This is called as Kassovitz law. Okay? That's what is important from this thing. Treatment we all know is benzathine penicillin. And also remember, we screen all our pregnant women in the first trimester with VDRL. But VDRL false positive reports bhi aa sakte. So we always confirm with a TPHA or a FTA ABS. Okay. But VDRL we do for all our patients. Okay. Now coming to the last topic of today is the important, of course, it's like a very vast topic. It's a 2-day topic, but we're going to do this in 1 hour with the most important things discussed. Okay, so we have a pelvis, and in the maternal pelvis, you should know there is an inlet. This is the pelvic inlet. This is the pelvic cavity from here to here, and this is the outlet. So you may get just an image saying identify which part is what. The inlet, then you have the plane of greatest dimension in the cavity and the plane of least dimension. Okay, jo inlet hai na, remember it is more of a transverse oval. This is the inlet. Okay, cavity में क्या हो जाता है? Circular हो जाता है. This is the greatest dimension. It's like a circle. Okay, but the least dimension is at this level. What is this? This is the ischial spine. So the least dimension plane is actually the narrowest part of the pelvis. Okay. And then you have the outlet, which is more of a vertical oval. So the shape of the pelvis is changing, and at the ischial spine, this has the least amount of space. This is very important, the types of pelvises. A gynecoid pelvis looks like this. You can see जो transverse diameter है वो slightly more than the AP diameter, slightly more, okay? And this is how it looks like. It's a nice roomy pelvis. And here normal labor happens. There's usually no problem in labor. Android pelvis में क्या हो रहा है? Can you see these? These are the ischial spines. Number 1, these are prominent. And can you see the shape of the pelvis is like a heart shaped. ये थोड़ा सा और ऐसे होना चाहिए था. Sacral promontory is prominent. This is android or a male pelvis. Okay. And this is responsible for obstructed labor and deep transverse arrest. Okay. Anthropoid pelvis is this pelvis where you can see it's a vertical oval, ऐसे elongated है. This is called an ape-like pelvis, and this is responsible for occipito-posterior positions. Okay, so remember occipito-posterior android में भी होता है, but anthropoid में ज़्यादा common है. So if you're given to mark a choice, please mark anthropoid as your first option. Okay. Platypeloid is a very flat pelvis. So you can see it's very, very transverse at the inlet, and throughout also it is more of a transverse pelvis. So here what do you see commonly? Asynclitism and face presentation. Asynclitism क्या होता है? That the head is not entering symmetrically. It is at an angle. Okay. And if it is at an angle, then the head can get stuck. Okay. And face presentation can be seen in a platypeloid pelvis. So remember, gynecoid, normal labor; android, obstructed labor, DTA; anthropoid, occipito-posterior; platypeloid, asynclitism, and face presentation. In the skull, what is important? In the skull, the anterior fontanelle is important, the posterior fontanelle is important. Anterior fontanelle is diamond shape, posterior fontanelle is triangle shape, because this is formed by meeting point of three suture line, the lambdoid sutures and the sagittal suture. This is formed by sagittal suture, coronal sutures and frontal sutures. So 4 suture lines are meeting. जब हम PV करते, this is what we are feeling, कि how many suture lines are meeting. Now, what are the important diameters? You should know this diameter. This is the biparietal diameter, which is the engaging diameter. Transverse diameter means the engaging diameter. This is 9.5 centimeter. That means the largest transverse diameter which enters the fetal pelvis, sorry, the maternal pelvis, that is called the engaging diameter, and that is the biparietal diameter. So there is only one largest transverse diameter, that is the BPD, that is 9.5 centimeter. But जो different diameters change होते हैं, वो हमारे anterior posterior diameters change होते हैं. These are also called the presenting diameters. Okay, and they change depending on the degree of flexion or extension. We will just come to this. Okay. So this is lie. You have here a longitudinal lie. Here you have an oblique lie. Here you have a transverse lie. This is very straightforward, nothing to it. Presentation क्या होता है? The part of the baby occupying the lower pole of the uterus. So here you have cephalic, here you have podalic or breech, and here you have shoulder presentation. Okay, now this is important. This is where your diameters will change. ठीक है, तो attitude क्या है? Attitude है flexion या extension हो रहा है, that is the attitude. Presenting part क्या है? Presenting part is basically when I do a PV, the part that I'm feeling overlying the os is the presenting part, and usko describe करने के लिए we use the term denominator. Don't get confused at this point. I'm just going to tell you the different diameters. So here you have a fully flexed head. In sub में, all 4 of them, the BPD is the engaging diameter और ये change नहीं हो रहा है. This is 9.5 centimeter. जो change हो रहा है वो anterior posterior diameter. So जब head fully flexed है, what is the presenting diameter? It is the suboccipitopragmatic, sob. Can you see when you cry, you look down, so you're crying, you're sobbing. So sobbing is 9.5 centimeters, suboccipitopragmatic. जब head सीधा है, it is deflexed. It is neither flexed nor extended. This is called the military attitude. Okay, and here the diameter is the OF, the occipitofrontal, from the occiput to the frontum. This is the occipitofrontal. Office, remember OF means office. Office में आप सीधा देख के काम करते हो लैपटॉप पे, है ना? So this is 11.5 centimeters. Some books will say 12, 12.5. Remember 11.5 if you can. Otherwise measurements याद नहीं हो रहे तो ये वाला चीज याद रखो, सॉब इज फॉर फुली फ्लेक्स्ड हेड, ओएफ इज फॉर लुकिंग सीधा डिफ्लेक्स्ड हेड. What is this? This is a partial extension. Okay, and this is a bro presentation. ठीक है, ब्रो में याद रखो ये जो डायमीटर है, दिस इज द डायमीटर, दिस इज द वर्टाइको मेंटल डायमीटर. ठीक है, वर्टेक्स से मेंटम तक. This is the largest diameter in the skull and this is 14 सेंटीमीटर. ठीक है, वो इतना लार्ज है कि वो पेल्विस में जा ही नहीं सकता, इसलिए ब्रो में obstructed labor होगा. It cannot progress further and you have to do a cesarean section. So bro is a direct indication for cesarean section because ये diameter इतना बड़ा है कि वो अंदर fit ही नहीं हो सकता. And then you have this diameter. This is full extension or face presentation, and this diameter is the submentobrachmatic diameter. Okay, and this is also 9.5. ये भी छोटू diameter है, ये भी छोटू diameter है, and this is also a small diameter. So if the head is fully flexed, yeah, fully extended, it is like a sphere, it's like a ball, so it easily goes inside. Okay, but the best one is a fully flexed head. Even compared to a face, a fully flexed head is the best. So SOB is 9.5, fully flexed head. Occipitofrontal deflexed head. Bro is mentovertical or verticomental, 14 centimeter, and submentobrachmatic is face, that is also 9.5 centimeter. Next, you should be able to see an image and tell the position. Position क्या होता है? Position होता है with respect to the pelvis. How is the baby? है ना? तो pelvis में 8 quadrant होते हैं, 8 quadrants. Anterior, okay, and left or right is very important to identify. Now, how will you identify? Most of the doubts I get from all of you are कि हमें कैसे पता लगे कि left कौन सा, right कौन सा है? Look at this pelvis. This is a patient who is facing you, right? So this will be her left side, this will be her right side. हमारा उल्टा होगा, है ना? She's facing you. Her pubic symphysis is here, her sacrum is पीछे, so this patient is standing in front of you. Okay, so look at these different diagrams. If the occiput was directly facing here, it would have been occipito anterior. This is a occiput which is facing anteriorly and on the left side. So left occipito anterior. Okay, this is left occipito transverse. This is now the occiput has gone posterior. So this is left occipito posterior. Similarly, this is right occipito posterior. This is right occipito transverse and this is right occipito anterior. So it's very just when you get such a question in exam, first thing orient yourself कि patient आपके सामने खड़ा है या आपके जैसे खड़ा है. ठीक है, and that's how you know what is right, what is left, what is anterior, what is posterior. Once you've understood that, it becomes very easy to determine the position. So first orient कि ये pelvis सामने खड़ी है patient या आपके जैसे खड़ी है, and then you will be able to answer it better. This is the mnemonic for the cardinal movements in left occipito anterior. Okay, every darn fool in Egypt royally eats raw eggs. Isn't it? There's no point going into details in the marathon lecture, but remember this: engagement, descent. Descent is a continuous process, but second step में हम डालते हैं usually. Flexion, the head has to flex. Then internal rotation, the head is born by extension. So crowning वाला stage होता है and उसके बाद head is born by extension. Then वो untwisting होता है neck का, that is called restitution. Then external rotation is internal rotation of the shoulders and then the body comes out. So every engagement, down, descent, full flexion in internal rotation, Egypt extension, royally restitution, eats raw is external rotation, eggs, expulsion of the body. Okay. Quick slides. What is induction of labor? ये last FMG पे question आया था. Induction of labor means you will do induction of labor in a patient who you want to have a vaginal delivery. मतलब अगर कोई contraindication to vaginal delivery होगा तो आप उस पेशेंट को इंडक्शन नहीं करोगे. फॉर एग्जाम्पल प्लेसेंटा प्रीविया, यू वांट टू डू अ सिजेरियन सेक्शन, व्हाई विल यू इंड्यूस लेबर? Induction of labor means induction of labor pains. Patient is not in labor, say severe preeclampsia, you want to induce labor pains, or mild preeclampsia, 34 weeks, you want to induce labor pains, or 40 weeks she's gone, she's not going to labor, you want to induce labor pains, or oligohydramnios. But जहां पे आपने normal delivery करना ही नहीं है, that will be a contraindication to induction of labor. Bishop score comes as a question. This is a score done prior to induction of labor to assess the favorability. मतलब patient को समझाने के लिए कि induction to delivery में कितना time लगेगा. Okay, is the Bishop score. So it is a mnemonic in itself. Bishop, B stands for bishop, I stands for effacement, ठीक है, S stands for station, H stands for hard or soft, मतलब consistency. O stands for os dilated, os dilatation, and P stands for the position of the cervix, मतलब posterior है या anterior है. So if you forget in the exam, the bishop itself is a mnemonic. ठीक है, effacement, station, consistency, dilatation, and position. So there are 5 components. And there's a scoring system which is not important for you to learn. नहीं learn करना है इसको, ठीक है, but मैंने इसलिए दिखाया because you have scores, and if the score is 6 or more, it means it is a favorable cervix. मतलब patient को मैं समझाऊंगी कि तुम्हारा तो आज डिलीवरी 100% पक्का है. I won't say 100% of course, but I'll say आज डिलीवरी हो जानी चाहिए, है ना. But if the patient has a score of 1 or 0, I will say ना इसमें 2-3 दिन लग सकते हैं, है ना. So the patient also knows you, and the attendants won't trouble you every 2 hours कि why isn't she delivering, why isn't she delivering. ठीक है. So this helps you assess the favorability, and I can also tell a patient with 0 or 1 कि अभी हो सकता है कि डिलीवरी ना भी हो या पेन्स नहीं स्टार्ट हो. So this is a good way to assess the favorability. Okay, so ऐसा नहीं है कि score poor है, you can't induce. Many of you think this way. No, you can induce, but the induction will take more time. Now, what are the drugs we can use in induction of labor? We can use misoprostol. It's available as a tablet. Okay, prostaglandin E1 के नाम से है. मतलब मीजोप्रोस्टॉल के नाम से है. इट इज प्रोस्टाग्लैंडिन E1. ओके, अब यहीं पे खत्म कर देते हैं मीजोप्रोस्टॉल. और कहाँ कहाँ यूज कर सकते हैं मीजोप्रोस्टॉल? We use it in MTPs in the first and second trimester along with mifepristone. So mifepristone plus misoprostol in MTP. और कहाँ यूज होता है? इंडक्शन ऑफ लेबर पे यूज होता है. और कहाँ यूज होता है? PPH में, postpartum hemorrhage, atonic. So remember, it is a uterotonic. It's a very strong drug. It causes sudden severe uterine contractions. So it's used in management of PPH, or in gynae cases, if we want to do a DNC suppose, तो हम misoprostol पहले डाल देते हैं. It causes cervical dilatation in a non-pregnant uterus also. Okay, so these are the uses of misoprostol. It's available as a tablet, so you can use it orally or you can use it mucosally. Mucosally matlab vaginally, rectally, buccally, sublingually, any mucosal route you can use it. Second drug is PGE2. PGE2 is also called as dinoproston. Remember, dinoprost is PGF2 alpha, but dinoproston is PGE2, and this is also commonly available as Servi prime. ठीक है, ये दिख रहा है Servi prime. Okay, so this is, or it's also available as a tablet. Okay, so it is available as the oral or vaginal tablet form. It's also available as a, the Servi prime is actually an intra cervical gel. So cervix के अंदर हम ये gel डालते हैं. Also you now get vaginal pessaries. So this also causes uterine contractions धीरे धीरे. It is much milder than PG1. PG1 बहुत strong है, PGE2 थोड़ा सा mild है. ठीक है, but remember prostaglandins, where will we never use? We will never use. So prostaglandins are contraindicated in a woman with a previous cesarean section. So if a patient with a previous section, you want to induce her, you will never ever use prostaglandins because they suddenly will cause uterine contractions and rupture uterus. ठीक है? तो patients with previous cesarean section फिर हम क्या prefer करेंगे? We prefer mechanical methods, okay? Like this, like putting in a Foley's or using a laminaria tent. Mechanical methods are preferred in previous cesarean, okay? और क्या मेथड्स होते हैं? ऑक्सीटोसिन. ऑक्सीटोसिन अब कहाँ कहाँ यूज होता है? इंडक्शन ऑफ लेबर. और कहाँ यूज होता है? ऑगमेंटेशन ऑफ लेबर. ऑगमेंटेशन ऑफ लेबर मीन्स शी इज गेटिंग पेन्स बट यू वांट टू इंक्रीज द इंटेंसिटी. पेन्स है बट कम है, ठीक है. यू ऑल्सो यूज इन एटोनिक पीपीएच. Also used where else? It is also used in breast engorgement. Okay, these are the few common uses of oxytocin. Other methods of induction, one is sweeping or stripping of membranes. This releases prostaglandins. Okay, an artificial rupture of membranes, but this can be only done if the cervix is more than 3 centimeters dilated. नहीं तो आप कर नहीं पाओगे. ये जो इंस्ट्रूमेंट है अब तभी इंट्रोड्यूस कर पाओगे अगर 3 सेंटीमीटर से ज्यादा ऑस खुला है. ये कौन सा इंस्ट्रूमेंट है? दिस इज एन ARM hook. Okay, so you can do an ARM with either the hook. This is the ARM hook, or you can use this forceps. It has a tooth at the end. You can see this is called a Coker's forceps. Okay. And then you have the mechanical methods. Laminaria tents not available in India. So we use the Foley's catheter को हम अंदर डालते हैं और फिर बल्ब को इन्फ्लेट करते हैं. इससे क्या होता है? प्रोस्टाग्लैंडिन्स रिलीज होके the patient goes into labor. Okay. Now, stages of labor, we all know the stages of labor. Stage 1 is from onset of true labor pain till full dilatation of the cervix. That means till 10 centimeter. And you can divide this into a latent phase and an active phase. अब active phase का definition पहले था 4 centimeters onwards. अब नया definition क्या है? This is old definition. Now WHO in 2018 has said it is 5 centimeters से ज़्यादा is active labor. Okay, so we are now following the new definition. उससे पहले less than 5 centimeter is the latent phase. Active phase starts after 5 centimeter. Now, अगर patient is having prolonged labor, मतलब she is not delivering on time, we have to check for 3 things. Check the power. Power means uterine contractions. So uterine contractions को बढ़ाने के लिए we can either do an ARM or we can start the patient on oxytocin, or we check the passage. Maybe the pelvis is chota, CPD, है ना? Or we check the passenger. Maybe the passenger is too big, okay? Or the passenger has some malposition or malpresentation, and we have to see what the problem is. So whenever you have prolonged labor, check the 3 Ps. That is very important. You can augment labor by doing an ARM or starting oxytocin. Okay. What is stage 2 of labor? Stage 2 is from full dilatation till delivery. Okay. Now, in stage 2, what is important is you can get a picture showing this maneuver. What is this maneuver? This is controlled extension of the head. ये controlled extension को कहते हैं Ritchon's maneuver. So the head is born by extension, but एकदम से नहीं बाहर आने देते. एकदम से बाहर आएगा तो perineal tear हो जाएगा, है ना? So it's a controlled extension, and that's called the Ritchon's maneuver. Okay. What about one more thing you should know in the second stage is about episiotomy. Remember, very important, we don't routinely give an episiotomy now. We give the restrictive, matlab kuch hi patients mein we give a restrictive. For example, if there's a large baby, 4 kg baby you're delivering, okay, or you have shoulder dystocia, the head comes out, the shoulders get stuck, or you're conducting a breech delivery. Or you are, what else? You are using a forceps or a vacuum. So in such cases, you will give an episiotomy, but we don't give it routinely. When is it given? At the time of crowning. Okay? Crowning ka matlab this. The head is seen without separating the labia. We prefer to give a mediolateral episiotomy. So this is a mediolateral and this is a median episiotomy. Both can be given. The disadvantage of median is it can go and make a complete perineal tear. It can go directly into the anal area and have a complete perineal tear. Okay. What are the structures cut in an episiotomy? From inside out, the vaginal mucosa, the muscle, and the skin. Okay, so when we suture it mucosa, muscle, skin. The same order that we cut, the same order we suture. This can come as an image-based question. This is an episiotomy, scissors. It is very nicely angulated यहाँ पे. Okay, so this is typically how it looks like. A very important third stage. Third stage is from delivery of the baby to delivery of the placenta. Okay. And delivery of the baby to delivery of the placenta. What is the most important thing we are doing? This is the AMTSL. That is active management of third stage of labor. Why are we doing this? To prevent atonic postpartum hemorrhage. Okay. And these are the main basic 3 steps which have changed over time, but ये 3 basic याद रखने. Administration of a uterotonic. What is the uterotonic of choice? It is oxytocin, 10 units intramuscular. Okay. Then controlled contraction and then massaging the uterus. So when the WHO came out, it said these are the 3 steps of AMTSL. But then it changed it a bit. In 2012, WHO ने क्या बोला कि oxytocin तो देना ही है, ठीक है, 10 units IM देना ही है. It added one more step, delayed cord clamping. Okay, this does not prevent PPH, but it gives you an opportunity to use this AMTSL to do a delayed cord clamping ताकि बच्चे को blood ज़्यादा जाए, and it prevents neonatal anemia. Third step is perform a controlled cord traction if required. मतलब placenta अगर अपने आप separate होके बाहर नहीं आ रहा है, then you do a controlled cord traction if required and by a skilled birth attendant. Okay. Uterine massage word hatake, they have written postpartum vigilance needs to be increased. What does this mean? This means that you have to increase your monitoring, and if the uterus is flabby तब जाके उसको massage करो, ठीक है, and ensure the quality and supply of oxytocin. And in 2018 WHO also said कि oxytocin तो use कर ही सकते हो, you can also use carbetocin, which is a heat stable analog of oxytocin, ठीक है. Oxytocin, remember, has to be refrigerated between 2 to 8 degrees Celsius. So many times the efficacy would be lost if the cold chain was not maintained. So it said you can use carbetocin, you can use misoprostol, you can use methyl ergometrin, but not in hypertensive or women with heart disease. And you can use a combination of oxytocin or ergometrin. इसको हम कहते हैं symptometrin. ठीक है. Then this image is important. This is this is how controlled cord traction is done. So one hand you are pulling on the cord, the other hand you are pushing the uterus upper. This is to prevent uterine inversion. This is called the modified Brandt-Andrews technique. Okay. Now, what does the WHO say? So in 2018, the WHO came out with this document about intrapartum care. So we'll just quickly go through the important points which you should know. First was कि active stage तक patient को admit नहीं करना है. routinely हम clinically pelvimetry नहीं करेंगे. That means we won't assess the pelvis by clinical examination. The baby itself will tell us whether the passage is adequate or not. Routinely we won't do a CTG. Okay, we won't routinely shave the perineum. We won't routinely give an enema. Okay, we'll do a PV once in 4 hours. We will give the patient good analgesia, make her comfortable, encourage movement, allow fluids and food, and routine में ये सब procedures नहीं करेंगे. Only if indicated we will do an ARM. Amniotomy क्या होता है? ARM. Only if indicated हम करेंगे. Only अगर जरूरत है we'll give oxytocin IV fluids. Otherwise routinely we won't give. Second stage question comes, what is the preferred choice for birth position? Answer is, there's no preferred choice. Allow the woman to deliver as she wants. She should follow the urge to push. इस पे क्वेश्चन आता ही आता है. Techniques for preventing perineal trauma. Remember, episiotomy is not a technique to prevent trauma. Putting a warm compress on the perineum, warm towel रखो perineum पे, massage the perineum, okay, and give perineal support. When the baby is coming out, support the perineum. These three things will prevent a perineal tear. Okay, तो episiotomy नहीं देना, ऊपर से धक्का नहीं देना, fundal pressure not to be given, episiotomy not to be given. Okay. And third stage is your AMTSL. Same thing which we have just discussed. Active management of third stage of labor करना है सब patients में. ठीक है. What is fourth stage of labor? It is the 1 hour of observation after the placenta is delivered. Again, antibiotic नहीं देना है. Vigilance करते रहना. Keep checking the uterus. Okay. And discharge her after 24 hours. Okay, now partogram pe, I'm not going to go into the details. I'm just going to tell you that in 2018, along with that document, the WHO has now changed the original partograph to the labor care guide. It is unlikely you will be asked a question. At the most, वो ये पूछेंगे कि start कब करना है. Start करना है at 5 centimeters or more. Okay, and it is to be done for all women in labor in any setting. ऐसा नहीं कि PHC में करना है, corporate hospital में नहीं करना है. No, it is to be in any setting in women who have dilated 5 centimeters or more. Okay. Now, so the modified partograph जो हम पहले करते थे उसको कहते हैं हम WHO modified partograph. उसमें if you remember 4 centimeters, but now we've changed this to 5 centimeter. पुराने partograph में there would be an action line and an alert line. Okay, alert line पहले आता था, फिर action line. But अब वो सब नहीं है. Okay, so that's not there. No action line, no alert line. Second stage has been added. पहले partograph में second stage नहीं था. पहले पार्टोग्राफ में there was no documentation of what interventions we're doing, but यहाँ पे वो सब है. Also there is supportive care, companionship. Does the patient have somebody with her? Has she been given pain relief? Is she taking adequate fluids? Is she mobile? Because उसको लिटा के नहीं रखना, we have to keep making her move. All this is part of the new labor care guide. There the main focus was on the alert line, action line. यहाँ पे the main focus is it's like a holistic approach. Make the patient comfortable, give her what she needs, start at 5 centimeters and document a second stage of labor. These are the main points you should know. Unlikely to be quizzed, I know, but something new, so I thought let me just add it. Okay, what should you know about breech presentation? I'm not going too fast now. If I'm going too fast, I'll slow down. Just give me a thumbs up if I'm fine. Okay, fine. Thank you. Thank you. Thank you. Okay. Etiology of breach. अगर question आता है, most common cause of breach is prematurity. Okay. So at 28 weeks, 25% of fetuses are breach. ठीक है. So most common etiology you should know. How do you diagnose breech? Clinically by the Leopold maneuvers. ऊपर आपको head दिखेगा, fundal grip पे you will find the hard ballotable structure. नीचे आपको broad वाला non-ballotable breech दिखेगा. And how will you confirm this? By doing an ultrasound. And ultrasound will also help you rule out causes for breech. Like maybe she has placenta previa, or maybe she's a twin pregnancy. Okay, or maybe there is a fetal anomaly, or maybe there's a Mullerian anomaly. So it also helps you, apart from diagnosis, find out the reason for breech. Maybe there's a large fibroid obstructing the uterus, so the baby can't move. Okay, so ultrasound is important. Now, when a patient comes with breech, the first thing, especially अगर वो 36 weeks to 37 weeks के बीच में आ रही है, the first thing we can offer the patient, if there is no contraindication, is an external cephalic version. That means abdominally, externally, we try to rotate the baby. We try to bring the head down. So when do we do this? When there's no contraindication to ECV, which I will just tell you. Also, when your aim is a vaginal delivery. ऐसा नहीं है कि placenta previa है and you're doing an ECV and then you do a cesarean. No. So when there is no contraindication to doing an ECV and there is no contraindication to a vaginal delivery. Okay, because this has its set of complications. You have to be very sure in your mind that your aim is a vaginal delivery and there are no contraindications to this procedure. Okay, so what are the contraindications of this procedure? Placenta previa, you will not do an ECV. Pelvis chota hai, ठीक है? Multiple pregnancy, this I'm talking about ECV in the beginning, right in the beginning. Okay, after one twin is out and the second twin becomes transversely, then you can do an ECV. But when both babies inside, you're not doing a ECV. If the head is hyperextended, इसको हम कहते हैं star gazing fetus. The head is like this, है ना? So remember, for ECV to happen, a hyperextended head is not a favorable position. If there is any Mullerian anomaly, it becomes difficult to do even if there's any fetal anomaly. Okay, and if there is a dead fetus or a distressed fetus or the patient denies consent. Important to remember, अगर question आता है, जो previous question आया हुआ है, previous LSCS, remember, is not an absolute contraindication. It is a relative contraindication to an ECV. ओके, प्रीवियस कार में यस थोड़ा सा ध्यान से करेंगे बिकॉज रिस्क ऑफ रप्चर है, बट एब्सोल्यूट कॉन्ट्राइंडिकेशन नहीं है जैसे ये वाले इंडिकेशन है. ठीक है. नाउ इफ शी इज मल्टीपैरस, अगर ब्रीच अंदर नहीं जा चुका है, लाइकर इज गुड एंड द प्लेसेंटा इज पोस्टीरियर, okay, that is non-anterior, your chances of a successful ECV are higher. The success rate of ECV is 60%. 60% chance hai ki you will be able to turn this baby. Okay. Now, second tha ki ECV patient has not consented, or patient doesn't fulfill the criteria for ECV, okay, or you can't do, or unsuccessful. So ECV आप कर नहीं पाए for some reason, then you have the option of either a vaginal delivery or a cesarean section. So say 36 weeks पे patient आई, आपने उसको ECV समझाया, question में आया कि patient denied giving or didn't give consent for an ECV. Now she is 38 weeks pregnant. What will you do? Okay, so now you have two options. You can either offer her a vaginal delivery, जिसको हम कहते हैं assisted breech delivery, or we can directly do a cesarean section. What are we worried about in a vaginal delivery? Is the head getting stuck. She's breech, the baby, the body will come out easily, but the head gets stuck. And this can happen in 10% of patients. Okay, so which patients are more prone to the head getting stuck will become factors against an assisted breech delivery. अगर प्राइमी ग्रेविटा है, मतलब pelvis कभी टेस्ट ही नहीं हुआ उसका, don't allow an assisted breech delivery. if she is preterm में क्या होता है, body छोटा होता है, head बड़ा होता है, head tends to get stuck. If the baby as such is big, if it's a stargazing fetus, if it's complicated breach का मतलब क्या है, breach with any other complication. For example, preeclampsia with breach. Okay, you're not going to do all this heroic things, okay, or GDM with breach, or IUGR with breach, okay. Previous cesarean with breach, this is also a type of complicated breach. I have never done a breech, assisted breech delivery, है ना, and patient is very willing, है ना, and my excitement में कह दूं कि नहीं, I'll do your delivery, है ना, no, that is also wrong. So lack of skilled personnel, it's very clearly given in the guidelines that a senior most obstetrician should be present who has the skill of having or who has done multiple assisted breech deliveries. Okay, वैसे I have done multiple assisted breech deliveries. Okay, and footling or kneeling. Footling or kneeling means the presentation is footling or kneeling. Then that means the foot is the presenting part or the knee is the presenting part. Again, you will not do all this. Okay. Okay, so these are important maneuvers in an assisted breech delivery. So you can get these as questions. This is Lofset maneuver. ये तब करते हैं जब hands आराम से नहीं आ रहे. That means the hands are somewhere ऊपर, nuchal arms or overhead arms. So you do the Lofset maneuver. Just look at this image. You're turning the baby by 180 degrees and then returning it by 180 degrees. Now, the main problem comes when the head gets stuck. Okay, so how do you deliver an aftercoming head? The simplest and the most commonly performed maneuver is the Burn Marshall maneuver. इसमें क्या करते हैं? We hold the baby from the legs यहाँ पे and we just sweep the baby over the maternal abdomen. So you pick up the legs from here and you sweep it over the maternal abdomen. And ये वाला हाथ जो है ना, your assistant's hand is continuously giving pressure here. This pressure is causing flexion of the head. So that's very important. So suprapubic pressure is important in assisted breech delivery because it maintains flexion of head. Okay, so Burn Marshall. Then this maneuver. This is less commonly performed, but you should know it. Morisot Smelly Viet. MSV maneuver. इसमें क्या हो रहा है? Assistant is giving suprapubic pressure for flexion and both your hands, one hand is holding the baby like this and your fingers are causing malar traction and flexion. So this hand is causing flexion and this hand is also pushing the occiput. This is also causing flexion. So basically all the three hands are promoting flexion and the head comes out like this. So this is the MSV maneuver. So you should be able to identify MSV, Burn Marshall, and Piper forceps. So the best way with minimal trauma, if the question comes, the answer is Piper forceps because it's a very controlled delivery. It avoids too much trauma at the atlanto-occipital joint. It prevents cervical spine injuries. It prevents intracranial hemorrhages. So Piper forceps is the safest way to deliver the head in a breech delivery. Okay. Next is shoulder dystocia. Shoulder dystocia, very simple, straightforward. What you should know, turtle sign. Turtle sign is when the turtle's head comes outside and then recedes back in. Matlab head bahar aa gaya, but shoulders are stuck. Shoulders don't come out. So when you see the turtle sign, you have to initiate the shoulder dystocia drill. That is the helper mnemonic. ठीक है, H is call for help. सबसे पहले help बुलाना है, फिर एपिजियोटोमी दिया नहीं दिया तो गिवन एपिजियोटोमी दिया है तो एक्सटेंड करो उसको, ठीक है. And then, so the question that comes is this one. What is the first maneuver that you will do? And this will relieve 80 to 90% of your shoulder dystocias. This is the Mac-Roberts maneuver. This is the Mac-Roberts maneuver, hyperflexion of the hip joint on the maternal abdomen. This is going to push the sacrum पीछे and disimpact the shoulder. Okay, so this shoulder gets disimpacted and most babies will deliver this way. Okay, so MacRobert. So the first line maneuver is help, episiotomy, avoid fundal. फंडल दोगे तो और impact हो जाएगा, and MacRoberts maneuver. Now also along with MacRoberts we also always give suprapubic pressure. जैसे हम breech में दे रहे थे, यहाँ पे we see this hand is giving suprapubic pressure. This is dislodging this shoulder. It helps in dislodging the shoulder. So MacRoberts with suprapubic pressure. The other maneuvers are not important. Just remember that ये जो है ना ये second line maneuvers है. Rotational maneuvers क्या है? Rubin and wood corkscrew. ठीक है? You can also try to remove the posterior arm or do the Gaskin. Gaskin is making the patient all fours. Okay, on her, make her ulta completely. Or the last resort is a Zavanelli. Zavanelli means pushing the head back and doing a cesarean section. Or even you can do destructive operations, cleidotomy. Baby के clavicle को fracture कर दो या pubic symphysiotomy. That means pubic symphysis को fracture कर दो. So you have these special destructive instruments. They are done only as last resort. Zavanelli, cleidotomy, symphysiotomy are last resort procedures. Usually by this time the baby has died. Okay, but as I said, most important question आएगा, MacRobert maneuver is the first maneuver that is done. Okay. Next comes, and I think this is the last topic. Yeah, maybe इसके बाद CTG है. Let's just see. Third stage complications, and most important is the postpartum hemorrhage. So postpartum hemorrhage can be within 24 hours or delivery or after 24 hours till 6 weeks postpartum, primary or secondary. Primary PPH के main 4 reasons you should know. The most common cause of primary PPH is an atonic uterus. Atonic PPH, that means the uterus is not contracting. Second most common is trauma. That means a cervical tear, a vaginal tear, a uterine rupture, a vulval hematoma. All this comes under trauma. Third is a retained placental bit inside, so tissue. And fourth is some coagulopathy. Okay, DIC or coagulation failure or ITP or some problem with thrombin. So T. Tone, trauma, tissue, thrombin. You have to remember the 4 T's of PPH. Now, the first thing you will do in PPH is you will, if you have PPH, the first thing, of course, is you will resuscitate her, call for help, ask for blood, and see if the uterus is relaxed or atonic. So if the uterus is atonic, what are you going to do immediately? You're going to do 2 things. You're going to start medical management and at the same time do mechanical management. Medical में क्या दोगे? AMTSL तो आप कर चुके हो, है ना? You given probably oxytocin. You can increase the oxytocin. You give it as an IV infusion. Or you can give other uterotonics. You can give methergin. You can give misoprostol. You can give PGF2 alpha. Okay. This is known as carboprost or prostodin. Now PGF2 alpha जो है ना, PGF2 alpha is given intramuscular. ठीक है? Remember, it is contraindicated in women who are asthmatic. Okay, because it causes sudden bronchospasm. So that's very important. Okay, this has come as a question. And at the same time, you're going to do mechanical management. Mechanical means by some compression method or tamponade, you're going to try to stop the bleeding. Now, mechanical methods are usually temporary. जब तक मेडिकल एक्ट नहीं करता या फिर जब तक ओटी ले जाके सर्जिकल स्टार्ट नहीं करते हो तब तक these are done. Okay, and in mechanical, what does the WHO recommend? You should know the WHO recommends bimanual uterine compression. That means putting your hand, a fist बना के एक हाथ अंदर एक हाथ बाहर से, just keep the uterus compressed. And it recommends an intrauterine balloon tamponade. Okay, and one of the common balloon tamponade equipments available is called the Bakri tube. Okay, which is a tube like a Foley's catheter can also be used, a condom catheter can be used, a Sengstaken Blackmore can be used, but specifically PPH का जो कहते हैं इसको हम कहते हैं Bakri tube. This is put inside the uterus and filled with 300 to 500 ml of saline. Okay, and this will give constant tamponade to the uterus and it may stop the bleeding, but zyadatar it is used for temporary, as a temporary method before you start surgical methods. Surgical method is done when medical and mechanical fail. What is this? You should know this image. This is a B Lynch suture. It's also called a vertical brace suture. So your bimanual compression, if it's working, then there's a very good chance that the compression suture will work. So there are other types also. This is the most common type. There's also Heyman sutures and Chose sutures. Okay, so B-Lynch, Heyman, Chose, these are all compression sutures. ठीक है, ये क्या है? तो compression sutures you can do, or you can do stepwise devascularization. That means cut off the blood supply to the uterus. So you can ligate 3 vessels, but on both sides, bilaterally. ठीक है, the first we usually ligate is the uterine. The second is the utero-ovarian anastomosis. Okay, which is here. ठीक है, and the third is the anterior division of the internal iliac artery. तो खाली internal iliac नहीं बोलो, better answer होगा anterior division of the internal iliac artery. These usually इसी order में करते हैं, but if the patient is very unstable, you may directly do an anterior division वाला, because this uterine artery is a branch of the anterior division of the internal iliac artery. See, this is the internal iliac, uterine artery is coming from here only. Okay. And the last topic for the day is, and of course the last resort, अगर इससे भी नहीं रुकता bleeding, तो you will do a hysterectomy. What is called an obstetric hysterectomy. The last topic for the day is intrapartum fetal monitoring, what we call the CTG. Can you see this? This is a CTG. नीचे वाला कार्डियो प्रोब है, फीटल हार्ट को चेक करेगा, ऊपर वाला टोको प्रोब है, यूट्राइन प्रेशर को चेक करेगा. सो कार्डियो टोकोग्राम. द सेम थिंग इफ आई एम डूइंग एंटीनेटली व्हेन द पेशेंट इज नॉट इन लेबर, तो ये टोको प्रोब नहीं होगा, सिर्फ कार्डियो प्रोब होगा. दिस इज कॉल्ड अ नॉन स्ट्रेस टेस्ट. ओके, let's just quickly talk about the non-stress test. It is a test for antepartum fetal monitoring. Other tests of antepartum fetal monitoring are the biophysical profile and the modified biophysical profile. What is the biophysical profile? It has 5 parameters. NST plus AFI plus fetal tone plus fetal movement plus fetal breathing. तो ये चारों AF actually amniotic fluid volume है. Amniotic fluid volume plus tone plus movement plus breathing are all ultrasound parameters plus an NST. So 5 parameters. But इसको करने में बहुत time लग जाता है. So a quicker way is to do a modified BPP. What is a modified BPP? And this very commonly comes as a question. Is just do an amniotic fluid index on the ultrasound plus take an NST. Okay, and this cuts short on time and is a much quicker test to do than a complete biophysical profile. Okay, now coming back to CTG. CTG ke remember 4 important components: the baseline fetal heart rate. Okay, the normal baseline is 110 to 160 beats per minute. फिर हम क्या देखते हैं? beat टू बीट वेरिएबिलिटी. इसका क्या मतलब है? इसका मतलब है कि ये जिगजैग लाइन ये नॉर्मल है, ऐसे दिखेगा तो इज एबनॉर्मल. सो अ नॉर्मल बीट टू बीट शुड बी 5 to 25 beats per minute. That means every second the fetal heart is changing, but it is within the range of 5 to 25. मतलब this zigzag thing is normal. Third is we look for accelerations Accelerations का मतलब fetal heart is going above the baseline, like this is an acceleration by 15 beats per minute or more, lasting for more than 15 seconds. ठीक है, तो this is an acceleration. These are all good signs. And deceleration is what should not be there. Deceleration is the opposite. मतलब a fall in the fetal, in the baseline by 15 beats per minute or more, lasting for 15 seconds. So these are bad signs. And whenever we see a deceleration, we see it in relation to the uterine contraction. So this is the TOCO part. इसलिए TOCO is important to correlate and find out कि ये किस type of deceleration है. Okay. I just will quickly go to the deceleration because that's the most important. So look at this deceleration. Can you see this deceleration and its relation to the fetal, to the contraction? See this one and see the relationship. See this one and see the relationship. So can you find a relationship? This is what kind of deceleration? This is an early deceleration. Why? Because जो dip है fetal heart का, जो prominent point है dip का, that is matching with the peak of the contraction. ठीक है? So early decelerations are normal, okay, in second stage of labor when the head is coming down, because the cause of early deceleration is head compression. Head कब compression हो, कब compress होगा, जब वो नीचे आ रहा है. ठीक है? And that is an early deceleration. So if you're seeing this, especially in the second stage of labor, you are not worried. Then comes this. ठीक है, एक तो इसमें दिख ही रहा beat to beat है ही नहीं, it's a flat line, so that's a very bad thing. Apart from that, look at this. The dip is happening after the contraction. The dip is happening after the contraction. So every time the dip happens, it is after the peak of contraction has gone off. Okay, this is called a late deceleration. Late का मतलब आप late हो गए हो. This baby is now hypoxic. So in uteroplacental insufficiency, जैसे absent reversal मैंने बताया ना, we don't usually try a normal delivery. Why? Because जैसे ही contraction आएंगे, you will find these kind of late decelerations. This baby is already hypoxic. उसके ऊपर से जब uterus contract कर रहा है, तो blood flow और कम जा रहा है baby को, that baby will show these kind of decelerations. Okay, so this is a hypoxic baby. If you're seeing these decelerations or your question comes that isme kya karoge, you will directly do a cesarean section and take this baby out. This is a hypoxic baby. And third is variable. Variable means there is no relation to the contraction. You know? So this is variable. Variable is seen in कॉर्ड कंप्रेशन. और कॉर्ड कहाँ पे कंप्रेस होगा? जहां पे लाइकर नहीं होगा, ओलिगोहाइड्रामनियोस. सो नॉर्मली लाइकर गिव्स अ नाइस कुशनिंग टू द कॉर्ड. व्हेन देयर इज नो लाइकर, फीटस जब मूव करेगा या फीटल पार्ट्स के बीच में कंप्रेस हो जाएगा. तो इट्स नॉट रिलेटेड टू यूट्राइन कंट्रैक्शन, it's just related to random fetal movements and the cord gets compressed. Okay, so variable deceleration has to be looked, the entire picture has to be looked at. You can't say variable hai to I'll do a cesarean. So the entire picture, usually the question comes as an image for variable. Here the question comes ki what next, and here also they commonly ask you in relation to second stage of labor. And the last one, not the last one, the second last one is this picture. What is this? This is a prolonged deceleration. Prolonged deceleration मतलब it started falling और बहुत लंबे टाइम तक रहा, फिर पिकअप हुआ. So any deceleration lasting more than 2 minutes is called a prolonged deceleration. And you can see here यहाँ पे beat to beat भी अच्छा नहीं है. It's a very bad picture that the fetal heart has gone low for more than 2 minutes. And the two most important causes are cord prolapse and abruption. So this is where you will see such a picture, severe fetal distress, that वो इतने लंबे टाइम तक वो नीचे ही रह रहा है, ऊपर नहीं आ रहा है. Okay, and the last one is this one. This kind of pattern is a sinusoidal pattern, and this is seen in fetal anemia. कहाँ देखोगे fetal anemia? in vasa previa, there's fetal blood loss. You'll see this pattern. And in an RH, iso-immunized mother, where there is fetal hemolysis happening and fetal anemia. Also in इसको MCQ बनाने के लिए, which of the following is where will you not see this pattern? तो कहाँ पे देखोगे? Third वाला, parvovirus B19 infection. This also causes fetal anemia. Okay, so the three causes of fetal anemia in pregnancy you should know: vasa previa, RH isoimmunization, and parvovirus B19. Okay, so that ends the class. ठीक है, तो आफ्टर योर एग्जाम यू आर गोइंग टू, आई नो अभी तो 5 कितने दिन बचे, 10 days बचे, 10 days, 9 days. After that, you please include all this in your schedule and take a good break. Okay, and tomorrow we will do gynae like how we did today. मैंने chat box खोला भी नहीं, मैं खोलूंगी भी नहीं, आप मुझे नहीं तो मुझे लगेगा बीच में I miss so many doubts. But message me separately. You all have my number. It's on the chat box. Okay, and see you all tomorrow. All the very best. Have a good night's sleep. That's also very important. Okay, thank you. Good night.